अशोक भाई वेलकम।
हाय काजी।
अशोक भाई वेलकम वेलकम।
थैंक यू।
सर
चला
डॉक्टर
गया।
नरेंद्र सर अभी ज्वाइन कर रहे हैं, 2 मिनट में ज्वाइन कर रहे हैं।
है ना?
हाँ
ठीक है,
डॉक्टर
तो दीपिका लाइव कर रहे हैं।
कैन वी स्टार्ट? वी कैन स्टार्ट विद द
हाँ।
हाय
इन्वोकेशन।
काजी।
अशोक भाई वेलकम वेलकम। अशोक भाई वेलकम।
थैंक यू।
अनीता शर्मा मैम ज्वाइन हो
सर
चुकी
डॉक्टर
हैं, वेलकम।
नरेंद्र सर अभी ज्वाइन कर रहे हैं, 2 मिनट में ज्वाइन कर रहे हैं।
हेमंत भट्ट सर भी आ गए हैं, वेलकम हेमंत भट्ट
Good
सर।
evening,
तो
everybody.
दीपिका लाइव कर रहे हैं।
कैन वी स्टार्ट? वी कैन स्टार्ट विद द
हाँ। हाय
इन्वोकेशन।
काजी।
अशोक भाई वेलकम वेलकम। अशोक भाई वेलकम।
थैंक यू।
अनीता शर्मा मैम ज्वाइन
सर
हो चुकी हैं,
डॉक्टर
वेलकम।
नरेंद्र सर अभी ज्वाइन कर रहे हैं, 2 मिनट में ज्वाइन कर रहे हैं।
हेमंत भट्ट सर भी आ गए हैं, वेलकम हेमंत भट्ट
Good
सर।
evening,
तो
everybody.
दीपिका लाइव कर रहे हैं।
कैन वी स्टार्ट? वी कैन स्टार्ट विद द
हाँ।
हाय
इन्वोकेशन।
काजी।
अशोक भाई वेलकम वेलकम।
Yes, yes,
थैंक यू।
be on time, Deepika, be on time.
अनीता शर्मा मैम ज्वाइन
सर
हो चुकी
डॉक्टर
हैं।
नरेंद्र सर अभी ज्वाइन कर रहे हैं, 2 मिनट में ज्वाइन कर रहे हैं।
हेमंत भट्ट सर भी आ गए हैं, वेलकम हेमंत भट्ट
Good
सर।
evening,
तो
everybody.
दीपिका लाइव कर रहे हैं।
Can we start? We can start with the
हाय
invocation.
काजी।
अशोक भाई वेलकम वेलकम।
Yes,
मेहुल
yes,
कुछ
be
गड़बड़ है
on
मेहुल।
time, Deepika, be on time.
अनीता शर्मा मैम ज्वाइन हो चुकी हैं। हेमंत भट्ट सर भी आ गए हैं, वेलकम हेमंत भट्ट सर। मेहुल ये रिपीट हो रहा है मेहुल।
Can we start? We can start with the invocation.
अशोक भाई वेलकम वेलकम।
Yes,
मेहुल
yes,
कुछ
be
गड़बड़ है
on
मेहुल।
time, Deepika, be on time.
अनीता शर्मा मैम ज्वाइन हो चुकी हैं। हेमंत भट्ट सर भी आ गए हैं, वेलकम हेमंत भट्ट सर। मेहुल ये रिपीट हो रहा है मेहुल।
Can we start? We can start with the Can we start, sir, now?
Yes. Yes,
Can you
Deepika.
hear me?
हाँ,
बीच में
yes, yes,
बीच में
yes.
echo कर रहा था. I think now it's fine. It was echoing
Now
it.
fine. Now fine.
Okay, so yeah, so we can just we are just starting. So good evening, respected seniors, distinguished faculty, and dear colleagues. On behalf of the organizing team, it gives me great pleasure to warmly welcome all of you today to the session of Well Women webinar series. We are truly privileged to have with us our chief guest and guest of honor, special guest, eminent speakers, respected chairpersons, all from various obs and gynae societies from across the country. And we start with seeking the blessings of God Almighty. So, Corona remedies, can we have the Vandana? So thank you so much. It is now my privilege to invite our program director for today's webinar, Dr. Sarfaraz Qazi sir. He has been instrumental in conceptualizing and organizing this academic initiative. Sir, I request you now to kindly start with the inauguration and introduce our chief guest and seek the blessings of all our seniors. Over to you, sir.
Thank you very much. Thank you very much, Deepika. And thank you very much, all the esteemed faculties, starting from Dr. Usha ma'am, Chandravati ma'am, Narendra Malhotra sir, Ragini ma'am, Hemant Bhatt sir, Bela ma'am, and all the president and secretary of the different societies. This is the Well Women webinar series we have started in 2025 last year. We have completed almost 60 episodes. In 2025, and now again we have started in 2026 on this prestigious platform of Well Women webinar series, which is conducted by Himmatnagar Obstetric and Gynecological Society with the help of our state organization of SOGO. On this platform, I am welcoming you all esteemed faculty. First of all, I need blessings from all of you. So please, can I have a CV of Dr. Usha ma'am?
Yeah.
Padma Shri, Dr. Usha Sharma ma'am, welcome. There are no words which are available to describe Dr. Usha ma'am's CV, if I will say in one word or one sentence. Starting from the Director General Medical Education of UP, she has contributed in each and every field of education, social things, awards, authoring the book, training, and doing the social work, and getting so many awards from the central government, working with the WHO, also working with the central government. Also, her achievements are like a milestones for the simple people or the career like us. If I will going to mention, first of all, she got the Padma Shri by our Honorable President of India in 1985. She is the pioneer in starting the laparoscopic ligation in 1982, where Srimati Indira Gandhi has given awarded a laparoscope to her. And then she started getting so many awards like the Priya
I
Indira
think
Gandhi
I
Pradarshini
think it's
Award,
enough,
Mahila
Dr.
Ratna Award.
Sarfaraz.
And she, ma'am, at least a few things I have to mention. She has visited so many countries under the banner of the WHO. And the main thing, even doing all these things, when we people didn't know I about the infertility, she went to country like Geneva and other countries to get training and advanced training in the microsurgery in Ohio also and USA also. Ma'am, stage is yours. Just give your blessings.
Thank you. Thank you very much, Dr. Sarfaraz, for saying such nice words. But I will like कि चंद्रा जी पहले अपनी blessings दें. She is senior to me and I think she should give her blessings first. Dr.
नहीं नहीं
Sarfaraz?
उषा पहले तुम करो बोल दो फिर मैं आराम से बोलूंगी
मैम ने पहले ही बोल दिया था कि उषा मैम है तो मेरा बोलना वैसे भी कम
और क्या
रहेगा।
मुझे
नहीं
करना
नहीं
कुछ
नहीं
कहना
नहीं
नहीं है
नहीं नहीं नहीं. Thank you very much,
मेरा
Dr.
काम संभाल
Sarfaraz.
का करती है नहीं है
It's a great pleasure for me to be with you all on the occasion of Well Woman webinar series 2, and it's a 11th episode. Actually, to be very frank, I never knew that you are having such a webinar series, and it is the 11th episode. And you are not only doing for a single society, you have collaborated so many society. If I name, I think Agra, Aligarh, Meerut, Muzaffarnagar, Muradabad, then you have Jhansi, Gurgaon, then Katni and Himmatnagar and Surat. I think there are 10 societies which you have incorporated. And credit goes to Dr. Sarfaraz as well as to Dr. Deepika. And today we have chief guest with me, Dr. Chandravati. She is just like my elder sister, and if I don't talk to her and don't see her for few days, मुझे इतनी बेचैनी सी होने लगती है कि कैसे वो समय आए मैं चंद्रा जी से मिलूं. And thank you very much, Dr. Sarfaraz and Dr. Deepka, for organizing this webinar and inviting me to be here so that I can meet my dear beloved Dr. Chandravati. And today we have guest of honor, master of ultrasound, I must say, Dr. Narendra Malhotra. And along with him, we have Dr. Ragini Agrawal, who is also a very, very learned lady, I must say. And then we have Dr. Hemant Bhatt, who is a special guest today. And the theme of this webinar is antenatal ultrasound. And all of us know that of course, Dr. Deepika Logani is the convener of the program, and that's why I congratulated both of you, because antenatal ultrasound is becoming such a thing कि 10 लोग 10 बातें करते हैं. और कोई कहता है भाई फर्स्ट ट्राइमेस्टर में ये करो, कोई कहता है नहीं फर्स्ट ट्राइमेस्टर में मत करो, कोई कहता है नहीं सेकंड ट्राइमेस्टर में ये करो. So the main thing is that we must know and we must be sure at what time which ultrasound is to be done and how it is interpreted. अगर आप करवा भी लेते हो और interpret नहीं कर पाते हो तो भी it is absolutely useless. So such webinars are really very, very important for all of us in our day-to-day practice, because if we will discuss things as we are discussing today, that we have got Dr. Bela Bhatt also. Everybody knows that she is also a great ultrasonologist on the Foxy, and we have today Narendra Malhotra. हम तो अल्ट्रासाउंड की कोई वर्कशॉप करते हैं तो बस नरेंद्र को फोन कर देते हैं, भैया तू आ जाना, तू सब संभाल लेना, एंड ही इज द वन who just organizes everything without any problem, and our every program is successful wherever we have involved Dr. Narendra Malhotra. And you know, today that Bela Bhatt will be telling about the antenatal first trimester ultrasound, and then we have Dr. Sarfaraz who will be telling us about the PCPNDT Act. We all know that this act came into force in 1994 to prevent female feticide and to curb the declining sex ratio in sex selection. Today I have a little bit sore throat. Actually, the problems which are related with PCPNDT is that it is a very, very strict ruling. And if anybody is caught, then certainly the punishment is imprisonment. And so we should be knowing each and everything about ultrasound. It is a great moment today that so many societies have been involved, and it is only the hard work of Dr. Sarfaraz and Dr. Deepika. And we know that antenatal ultrasound with a different perspective. Antenatal ultrasound is a double-edged sword. As we can be caught through the PCPNDT Act if done again and again, but we can certainly miss many anomalies if the scan is done delayed. So दोनों तरफ से मारे जाते हैं. अगर हम ज्यादा करते हैं तो PCPNDT Act है, अगर हम करते हैं तो कभी कभी हम लोग उसको मिस कर देते हैं. And so the scan is delayed, then naturally we can miss it. The introduction, I will say one thing, that the introduction of inverting the antenatal pyramid concept, we are resorting to ultrasonography more in first trimester. And in first trimester, we know that early NT and NB or anomaly scan is capable of diagnosing at least 80 to 90% of the major anomalies. And this is then followed and we know that then we can do TIFA, which is done between 18 to 22 weeks, and in between probably we will not need anything else, and the other anomalies you can have at 18 to 22 weeks. And Dr. Bela Bhatt, as we know, is a star ultrasonologist, and she will be talking about first trimester, and Dr. Sarfaraz will be talking about the PCPNDT Act. And then we have today the panel discussion, which will be moderated by Dr. Divya Singh. And we know that this discussion is to just know how to do the things and how we can navigate second trimester anomalies and how we can have the details of the problems in any patients. So the main thing is that we should all be very, very careful in doing antenatal ultrasound, whether it is first trimester or second trimester, and we should always avoid to do repeated ultrasound and should be very precise that we should do this thing at this stage and this thing at this stage. And when you do it, please be sure that the interpretation is very, very good. If all these things are taken care of and everything will be sorted out. And thank you very much, Dr. Sarfaraz, for making me a part of such a prestigious webinar. And I am sure with star-studded faculty which you have today for the webinar, everybody will be greatly benefited from their experiences. And I think tomorrow, when all of us are just doing these ultrasounds, we will think twice and we will remember what the speakers today have talked about antenatal ultrasound. Thank you very much for making me a part of this. I wish this program a great success. And thank you very much that you called Chandraji also, that I could meet her today, and it was a real pleasure for me. Thank you very much.
Thank you.
Thank you very much, ma'am, for your word of wisdoms. Thank you very much. We always need your blessings in each and every step we are going to take with this webinar. I just want to mention that we have started this webinar on the basis of our Himmatnagar society, and first 10 episodes we did in our area just to take the lift up, where we didn't have any sponsor. We did all the webinars on us. We are the small society of only 79 members, and now we have started to move to the national level. Thank you very much for your blessings, ma'am. Our next chief guest is none other than the Dr. Chandravati ma'am. It's a great honor to welcome Dr. Chandravati ma'am, a distinguished personality whose vision, leadership, and dedication have made a remarkable impact in the field of obstetrics and gynecology. She has started her career as a HOD of KGMU, and now she is the professor of Emirates Department of OBGYN Department of the KG Medical College. She was the Foxy Vice President in 2001 and 2002. Also the governing council member for ICOG, organized so many conferences, and right now she is the proprietor director of the Krishna Medical Center, Lucknow, which is I am also affiliated with this center in Gujarat. We are doing Manyata work under her center's leadership, and she is also the patron of the Indian College of Maternity and Child Health, LOGS, APGL, UP chapter of IFS, UPCOG of Lucknow. Thank you very much, ma'am. We need your blessings and word of wisdoms.
Thank you. That's, I think, too much to make you remember what I am today. It had been a great journey through my life, and I was very happy when you really invited me for this platform. And it was, my main intention was to meet so many people like Usha, Narendra, Ragini, everyone, Ritu, so many people, Ragini, everyone is there. Thank you again very much. The topic you have chosen, I think it's what Usha said, it is very important topic. We must discuss about it. But I want to tell some different point about this ultrasound diagnosis and other things. There are lots of people who, technicians bought their ultrasound machines with the name of a doctor, and so many technicians are doing ultrasound. So we have to be very, very careful when we read the report of ultrasound with our patients. We have to go into detail whether the report is right or not right. And it is always better to confirm these reports. We know that if we detect anomaly in the first trimester before 11 weeks, the termination becomes very easy for us. If we detect anomaly before 24 weeks, termination becomes legal for us to terminate it. But if we delay, or sometimes if we miss the anomalies, the termination becomes difficult for us. We cannot terminate, and the woman has to carry an abnormal child throughout her antenatal period. So I'm very pleased that we have chosen this topic. I always want my all juniors, everyone to learn about ultrasound, to know about ultrasound, and it is very popular these days. You can go for training for ultrasound, know the basics of ultrasound, at least do the basic ultrasound, and advanced ultrasound can be referred to the ultrasonologist. And I feel this some webinar is very, very important. So many renowned chairpersons and speakers are there. Dr. Bhela Bhatt, Dr. Narendra are there to navigate through the ultrasound reports. I wish you all the success and good luck for this whole webinar. And I wish that we will be connected in the next webinar also. Thank you very much.
Thank you very much. Thank you. Thanks a lot, Chandravati ma'am, for your blessings. And it's with your blessings, we are moving forward. Our next guest of honor, none other than Dr. Narendra Malhotra, sir. It's my proud privilege to welcome Dr. Narendra Malhotra, sir, the eminent expert, visionary leader of the Foxy, whose guidance and achievements continues to inspire the generations like us. Uh, Apart from all the achievement, he is like a friend of friends, and he is a great photographer also. I have witnessed so many photographs of the Narendra Malhotra, sir. He was the past Foxy president. So many papers and chapters. He has published over 500 presented papers, over 1,000 guest lectures, more than 60 orations. Right now, he is the director of the ART Rainbow. Each and every field of the obstetrics and gynecology, not only sonography, like he is the national director of Ian Donald School of USG, but he is involved in laparoscopy, IVF, ovarian rejuvenation, and he is the professor of Sarjau School of Science and Technology in Croatia, another international university of Croatia, professor of the Indian Medical Association, and past vice president of SAPOG and WMP. He is also the editor of 66 books, the huge number editor of series of step-by-step books, and revising editor Jeff Cott, revising editor Donald. So many awards with his name, starting so many lifetime achievement award from the all the associations, starting from ISSRF, ISAR, Foxy, IOG, INSER, Ian Donald. So many awards under his belt.
Thank you.
Sir,
Thank you.
sir, need your blessings, and please, your words of wisdom.
A very good afternoon, good evening to all of you. It's indeed a pleasure to be here associated with this wonderful series on women's health, and series 2 and 11th episode or 12th episode, as I came to know. As you heard from the very two senior mother-like figures for me, Dr. Chandravati and Professor Usha Sharma, that ultrasound was the best invention which this century has had. If two things changed women's life, it was the oral pill to have control of her reproduction and ultrasound to see inside the Pandora's box. And I worked with Professor Ian Donald, I worked with Professor Asim Kuriak and Stuart Campbell to know what really ultrasound, how it came. And we were trained in ultrasound in Bombay KEM in 1982 when there was only 1 or 2 machines in India. And Professor Kelkar, the radiologist, used to come at 6 o'clock in the morning to do hundreds and hundreds of ultrasound. And that is how we learned ultrasound. Now, remember, the obstetricians do not have to be scared of doing ultrasound. So many of the obstetricians have left doing ultrasound because of PCP-NDT Act. Follow the PCP-NDT Act and do your own ultrasound so you understand. Now, for me, or for the guidelines, 5 times ultrasound should be done minimum in a pregnancy. One is when she comes to you for viability scan and for location. So you do not miss an ectopic in the first. The second scan is the NT-NB, which we'll be discussing, which is the most important scan. And along with NT-ND, you have to do an extended first trimester screening. So you rule out preeclampsia and all the other things. And here color Doppler has to be used. If your ultrasoundologist is not giving a report of uterine artery PI at 12 weeks or at the NT, please send the report back. Get a report of uterine artery PI. Do the PIGF and the extended first trimester so you can predict preeclampsia, which is the dreaded disease more than what congenital anomalies are. Preeclampsia is 15%, anomalies are only 2 to 6%. So, and 80% anomalies will be picked up here, chromosomal anomalies and even structural anomalies, which we'll hear. The next ultrasound is your anomaly scan or TIFA scan at 18 to 24 weeks, whichever is there. And here again, color Doppler is used to see if implantation has been complete. Placentation has been complete, so again you rule out PIS. Then a color Doppler to be repeated at 28 weeks, a growth scan, and for late fetal growth restriction, another ultrasound at 34 weeks. After that, you can do it every day if you want to see the liquor and see the presentation, whatever. But these 5 ultrasounds a pregnancy must have to have a healthy pregnancy. And out of this, only 2 scans are required by an expert. That is the NT-NB scan and the TIPA scan. The rest, all obstetricians should do all the other scans themselves. And if they are trained, they should do the NT-NB also and report it without any hesitation and do the anomaly scan also. So with those few words, wish you good luck, and of course be aware of the PCPND Act. You cannot say, I don't know, I did not read that book. It's a 20-30 page book. You've read Gray's Anatomy. Just reading another 20-30 pages of PNDT Act book is no big deal for any obstetrician gynecologist. Read it, understand it, and today Sarfaraz will tell us how to understand PCPND Act and how to follow it. Wishing you all the best for this webinar. Wishing you greetings on Women's Day. Women's March is also the yellow month of endometriosis awareness. So let's be aware of endometriosis. Today is also the Kidney Day, World Kidney Day. So let's support kidney health also in adults and in everyone. Wishing you all the best. Good luck for this webinar. Thank you.
Thank you very much, sir, for your word of wisdom, for your blessings, and let us to understand the basic and advanced of the ultrasonography. You are like a father figure for the ultrasonography. If you will speak, if you will think anything about the ultrasonography, the first name came in our mind is the Dr. Narendra Malhotra, sir, and no one else. Thank you very much, sir. Thank you. Our next
Thank you,
is
sir.
Dr. Yeah, Deepika, you want to say?
Yeah, thank you so much, sir, and to all seniors. अभी तो चल रहा है हमारा inauguration. अभी Dr. Sarfaraz is going to be introducing Dr. Ragini ma'am. But just to, I think आप लोग को पता भी है, Dr. Sarfaraz is standing for the election for chairperson of Foxy committee.
अरे वो बाद में, वो दीपिका बाद में, वो ब्लेसिंग ले लो पहले, अभी वो नहीं.
थैंक यू सो मच. ठीक है.
अरे अभी नहीं, है ना, वो ब्लेसिंग्स
बाद में. आई थिंक ब्लेसिंग्स तो है ही, ब्लेसिंग्स तो है.
बस वो है सब साथ में. Our next guest of honor is the visionary leader of the north of India, whose dedication and excellence have left a lasting mark in the field. She is Secretary General of IMS right now in 2025. Started with Joint Secretary in 2023. She in particular is the founder, sometime founder president, sometime founder chapter, sometime founder secretary of so many societies of Gurgaon and that particular part of the India of the Haryana, like founder president of Haryana chapter of ISOPAP, founder president of NIGF, and president of Indian Academy of Cosmetic Dermatology and Gynecology, and founder president of INSERG in 2022. She has so many awards with her. अरे मैम थोड़ा आपकी तारीफ में बोलने का सर्फ हमें हासिल हो जाए.
पब्लिक सुनने आई है एकेडमिक्स को.
मैम दो चीजें. The thing is, she got CL Zaveri's ICOG Symposium Award in 2024, and she has so many publications, editors, and authors in so many work. Apart from that, she is the great social worker and the project director of so many things, and project director in working with the women on the ground. Now the stage is yours, ma'am, and need your words of wisdom and blessings.
Thank you so much, Dr. Sarfaraz, for your kind word. Very good evening to one and all. And it's my honor to share this dais with none other than Chandravati Madam, Usha Madam, and the person who really I followed in my life is Dr. Narendra Malhotra. Thank you so much for this honor. And friends, I will not take much time. Everybody has spoken. I will just say one thing. For me, obstetrics is under a scanner today. If we don't understand our ultrasound, it's very difficult to practice the obstetrics. So this particular webinar is very, very important. And I think if you are able to do ultrasound, nothing is better than that. But as Madam Usha Sharma said, and Dr. Chandravati has also said, that we should at least able to understand the report. And it is very necessary who is doing to see. If you're not comfortable with the ultrasonologist, please repeat your ultrasound, but don't give any decision on that particular ultrasound. And at the end, I just say the name of the webinar is Well Woman Webinar. So a happy woman is only then a happy woman when she has a healthy child. So over to you, Dr. Sarfaraz, to continue the academics. Thank you so much for giving me this opportunity. Thank you so
Thank
much.
you very much. Thank you very much, ma'am. With your words
ma'am, for
of
your
wisdoms and your blessings, we are moving forward to our special guest, our convener of SOGOG, the State Organization of Gujarat Society of Obstetricians and Gynecologists. He is like a big elder brother or companion who is always guiding me in my career through every part of my career. He is always with me, and he is the like he's not only the teacher for the academics, he's the teacher for the whole life for me. Dr. Hemant Bhatt sir is a medical legal expert from our area and is the national convener of FOX in 2020-21, organizing secretary of AICOG in 2017, organizing chairperson of SOGOG 2070, joint convener in 2022-24. Right now, he is the convener of the SOGOG and delivered many talks related to the OBGYN and medical legal things. And now stage is yours, Dr. Hemant Bhatt sir. Please, your blessings for these webinars and upcoming all the webinars and for well-being of the woman.
Thank you, Sarfaraz, for the kind words. And at the outset, let me thank the Well Women Webinar Series program, particularly sponsored by the Corona Remedies and the program director, my dear friend, Dr. Sarfaraz, and the convener, Dr. Deepika, for inviting me for today's webinar. The crux of today's academics has been righteously described by our respected Dr. Usha ma'am. We got the blessings of Dr. Chandravati ma'am as well as Dr. Narendra Malhotra and Dr. Ragini ma'am. And let me finish what Dr. Deepika started. Our dear colleague, Dr. Sarfaraz, will be contesting for the chairperson of Medical Legal Committee of FOXI just 3 to 4 months afterwards. And it is our a kind of a duty to select such an enthusiast who is so much interested in academics and who will be there at the stage of FOXI to contribute by himself in a positive manner, and particularly the medical legal committee. The topic of today, which he is selected for deliberation, is also a PCPNDT Act, which is very much a part of our day-to-day practice now. And Dr. Ragini and Dr. Narendra Malhotra sir has rightly said that now obstetrics and the ultrasonography has become the two sides of the same coin. So an obstetrician cannot just imagine his or her practice without an ultrasonography or the understanding of an ultrasonography. And what more can be a good opportunity where you are having Dr. Bela Bhatt and the other our esteemed colleagues who will be deliberating on both the NT-NB scan of the first trimester as well as the second trimester scan, the detection, and afterwards the decision regarding the scan of the second trimester. So without delay and taking much of the time of all our esteemed colleagues, let us straight away go to the webinar and start having the deliberations of the academics. My all the best to the Well Woman webinar and many congratulations for completing the 60 episodes in the previous year and this 11th episode of this year. Thank you very much.
Thank you, sir. Thank you so much for your blessings. We are today really deeply honored that we, our chief guests and guest of honor and special guest have given us your blessings and blessings to Dr. Kazi for his election, sir. With this, and I take your permission to formally conclude the inaugural segment of the webinar. And can we move forward with the scientific proceedings of the day? Dr. Kazi, can we move
Yes,
forward?
with the blessings of all the esteemed guests.
Dr. Hazi, Dr. Bharti here, I have to leave in emergency. So
Yes.
I just want to say best wishes. Dr. Haji, I know you for a long time. And
Thank you very much, ma'am.
thank you for taking Merit Society in. And we are going to have a very interesting session in next few hours. And
Thank you
thank
very
you very
much.
much and best wishes. Yeah.
Thank you very much. Thanks a lot, ma'am, for
Thank
to
you, ma'am.
joining in the emergency also. That's showing courage and commitment with the academics. Thank you very much, ma'am. And
Thank
for
you.
that, you are known in all over the India like a great academician.
Yes, ma'am. Thank you, ma'am. Thank you so much, ma'am. So now with the blessings of our seniors, we will now begin with the scientific session. It is my privilege to introduce the distinguished chairpersons for the first session. Our first chairperson is Professor Tamkin Khan, ma'am. Ma'am has over 30 years of teaching experience and has contributed extensively to the academic literature with numerous papers and index journal, in indexed and peer-reviewed journal. Ma'am is currently the president of Aligarh OBGYN Society and also the vice president of UPCOG. Ma'am has the distinguished privilege of being the founder secretary of Stillbirth Society of India and has received several recognitions for her academic and professional contributions. Thank you, ma'am, for coming on board for this session. Our next, please. Our second chairperson for the session is Dr. Manju Prabhakar, ma'am. Dr. Prabhakar is professor of Obs and Gynae at Muzaffarnagar Medical College and is highly respected academician and clinician. Ma'am is the president of Muzaffarnagar OBGYN Society and has the distinction of serving as its president for 3 consecutive occasions. She has numerous academic publications to her credit. Thank you, ma'am. We are honored to have you. Our next chairperson is Dr. Vidya Chaudhary, ma'am. Ma'am is the professor in Department of Obs and Gynae at Maharani Lakshmibai Medical College, Jhansi, and currently is the secretary of the Jhansi Obs and Gynae Society. She has received several prestigious fellowships from ICOG and ICMCH and has numerous publications to her credit. She has also authored and co-authored several academic textbooks. Thank you, ma'am, for coming on board. And our next chairperson for the first session is Dr. Neeru Thakral, ma'am. Ma'am is the director of Thakral Hospital and Fertility Center and has completed a fellowship in reproductive endocrinology and assisted reproductive technology. Ma'am is currently the secretary of Gurgaon OBGYN Society and has special interest in assisted reproductive technology, reproductive endocrinology, and endoscopic gynae surgery. We welcome all our chairpersons for the first session. And could I request our chairpersons to introduce our speaker for the first session, who is none other than Dr. Sarfaraz Qazi, sir, and he will be speaking on PCPNDT Act, what an obstetrician should know. So could I request Professor Tamkin Khan, ma'am, can you introduce? Ma'am, are you there? I think she was there. She's there, but I think she's muted right now. Dr. Manju Prabhakar, ma'am, would you like to introduce, sir?
Definitely so. Thank you so
ma'am.
very much, Dr. Sarfaraz and Dr. Deepika, for inviting me as a president of Muzaffarnagar Obs and Gynae Society. Dr. Sarfaraz Nawaz Qazi, we all know her very well. He has done his DNB, MD, DGO, FICOG. He's an oncogynecologist and specialist in painless deliveries and high-risk pregnancies and endoscopy and infertility specialist. He's director of Navjeevan Women's Hospital, Himatnagar, consultant gynecologist, endoscopy and infertility specialist since 20 years. And he has experience in running high-risk pregnancy unit since 20 years at Himatnagar. He has done his MBBS DGO MD from BJ Medical College, Ahmedabad.
Ma'am, thank you very much. Ma'am, thank you very much.
No, thank you, because I have heard you reading the biodata of all the our eminent teachers, and they all were asking you to stop, but you were not. So I will also not. So the fellowship awarded in 2024 by Indian College of Obstetricians and Gynecologists, fellowship in reproductive medicine, and he has diploma in endoscopy, and he's a member of so many societies and North Zone coordinator of Gujarat chapter ISAR 24-26. So now
Thank you very
the
much.
stage
Thank
is
you.
yours, Dr. Sarfaraz.
Thank you for the nice introduction,
Thank you.
Dr.
Thank
Manju
you, ma'am,
Prabhakar,
for
ma'am.
introducing. And
Yeah,
sir,
yeah.
the stage is yours. Please
I'm
share your
one.
screen.
Yeah, one teacher has told me that if there is no hurdle in your way, think that you might be on the wrong path.
Okay.
So while starting this webinar, I was checking my slides so I am checking my slides whether they are sharing or not, and it was not sharing. So I understand that this is my right path.
You're right, sir.
So I ask the organizing people of the webinar just to share my slides from their side.
And while, sir,
So-
you are sharing your slides, I'm requesting, because, some doctors might be busy and might be logging off, and some would be joining. So sir is a candidate for, or is standing for the elections of chairpersons of the Foxy Medical Legal Committee, and which the elections will be in August. So kindly please support sir's candidature. And
And the
he is
nomination
also
will
the.
come in May.
Thank you, sir.
Nomination will come in May. So also please nominate
Yes.
from your side. Mehul, you are
Thank-
sharing from your side, na? You can go to the next slide.
Yes,
Mehul.
sir. Yes, sir.
I will
Yes.
say next, then you will go to the next.
Yes.
So I bring greetings from the land of unity and truth, the land of Mahatma Gandhi and Statue of Unity of Sardar Patel. I'm going to talk in a brief regarding the PCPNDT Act. We all have heard the name. We all have go through the things which are occurred according to this act, which was amended in 2003 recently, which so many new clause has been included in the previous law. The thing is, technology should empower the life, but not decide who deserve to be born. This is the theme of this talk. Next. If we will see the involvement of the female in our culture, in our nation, nationally and internationally, our history would not be written in this golden book without all the legendary females. If we will talk about our guest also, Dr. Usha ma'am, Dr. Chandravati ma'am, they are the pillar of our society. India's growth story cannot be written without its daughters, and about 460,000 girls went missing at birth between 2013 and 2017. It represents the devastating human cost of gender discrimination. Next. And this declining sex ratio is not just statistic, it is a mirror of our collective conscience, and we are here to make it reverse. And we all need to reverse this graph. This graph is showing that only one state is there where the child sex ratio is 1007 according to the last NFHS 5 survey. Next. So introduction. Is started by the Constitution of India, stipulates that the equal rights for all, regardless of the gender. Therefore, a woman should never be discriminated against for being a female, and she has an equal role in the society. But some fundamental causes for increasing female patricide cases in the country, due to the male preference, some gender bias and illiteracy are occurring. Next. These are the stages from where the final PCPNDT Act has been passed in 20th September in 1994. I must say and congratulate the people of the Maharashtra or the government of the Maharashtra, who were the first who made the law in 1988 under the name of Maharashtra Regulation of Prenatal Diagnostic Tactic Act first in India, and the implementation after the Supreme Court judgment has done in 2003, the final PCPNDT Act has been implemented. Next. This all the background why it is occur and what it applies to whom. It applies to each and everyone. Any preconception techniques, any prenatal diagnostic procedure, any genetic counseling centers or ultrasonography centers, it also covers not only the private sector, it also covers the public health centers also. Next. What we must know about this act, why I'm here to discuss the few critical key things we must know in our day-to-day or daily practice. What is the legal framework of this act? What documentation we have to fill, we have to complete it, and any leach or any breach in the documentation can be considered as a violation of the act. We have to be compliant with this act, and we must know what are the penalties if we are going to be caught violating this act in either manner. And we all particularly know that we as a gynecologist are frequently implicated under this act, not because we are doing anything wrong intentionally, but because due to the lack of awareness, some clerical errors and non-compliance with the documentation. So understanding this act is very essential in our day-to-day practice to protect ourselves legally. Next, who is covered under this act? We, the gynecologists, all the radiologists who are having the sonography machine or even the echo machine, sonologists, genetic counselors, the owners of the clinics where the sonography is taken up, hospital administrators, and even staff involved in the counseling and record maintenance are covered in this act. Next. I will go through some particular section which are implicated, which we encounter in our day-to-day practice. According to the section 3A, the important section is that sex selection before or after conception is strictly prohibited regardless of the method we used, and no medical, social, or personal justification is acceptable for sex selection under the PCPNDT Act. Next. And according to section 4, which is about the regulation of the prenatal diagnostic techniques. So any deviation in case in any prenatal diagnostic techniques may be used only for specific medical indication, which indications: chromosomal abnormalities, genetic metabolic disorders, congenital anomalies, or sex-linked genetic disease. Any deviation is punishable. Next. And you must document the indication. You cannot use the vague term or copy paste indication for any prenatal diagnostic procedure. Next. And if you will found that the indication is not matching with the technique, then you may be considered as the violating the act. Which prenatal diagnostic procedure are included in this PCPNDT Act is ultrasonography and taking or removing the sample of either amniotic fluid or chorionic villi or blood or any tissue or fluid of a man or a woman, and before or after the conception, for being sent to genetic labs for conducting any type of analysis or prenatal diagnostic test for selection of sex, it is considered in this act. Everything is considered in this act, not only sonography. Next. According to section 5, what is the importance of the written consent of the pregnant woman before doing the or before performing any diagnostic procedure? Please understand, consent should be taken, must be taken before performing any diagnostic procedure, not after or during the procedure. One of my colleague was caught doing ultrasonography without taking the consent. The form was going to be filled up with the staff. Patient was on the sonography table. She was doing the sonography. Consent of the pregnant woman was not there. And the justification what the gynecologist she was giving to the inspection authorities that I am doing the sonography, my staff is filling the form. After finishing the sonography, before giving her a report of the sonography, we are going to take the sign. And she is caught for this reason, and her machine was sealed for 6 months. So understand what is the importance of the written consent. Woman must be informed about the purpose, risk, and limitation of the test in a language she understands. And it is a mandatory declaration must be obtained stating that the sex of the fetus will not be disclosed, and this declaration protects not only a gynecologist, also the patient. Next. Section C, which describes the prohibition of sex disclosure in any form, whether it is verbal, written, symbolic, or gestural, and even indirect communication or causal remarks can be taken as a violation of the act. Next. This is very important. We knew many things about the which should be performed, written consent, documentation, form, map, everything. But many of our gynecologists did not know about the registration process. See, Recently, they have said that before 1 to 3 months of expiry of your registration, you have to renew because it will take some time. If you will not do this, in between time, you cannot do the ultrasonography if you are not renewing your registration before the expiry of your registration certificate. So all genetic clinics, ultrasound centers, and diagnostic facilities must be registered under this act. Practicing without this registration is punishable offense, and there must be a display of the registration certificate with the warning boards and sign and notices which stating that the sex determination is illegal and it is not performing here should be there. Next, like this on a place where you are doing the sonography, this signboard should be there, and also in your hospital outside your consulting chamber, it should be there where there is a waiting area of the outpatient department. Next. Record maintenance is must, and this record maintenance should be it is the backbone of the compliance under this act. Incorrect records are the most common cause. In today, 80 to 90% of cases are of PCPNDT Act which are in court because of due to the incorrect or inadequate record maintenance. Next. This is like our lifeline in our consulting chamber, Form F. It has a very great legal significance. It must be filled completely, accurately, in time, with signature, and it is the primary legal document whenever there is an inspection from the district health authority or state or national health authority in your clinic, and in each and every court proceedings, Form F is taken as a primary legal document. And what are the common errors? As I told, missing the signatures, wrong side signatures also. If you are mentioning incorrect gestational age, incorrect indication, mismatched indication, incomplete forms, wrong date or year, delayed entries, these errors are often interpreted as a intent to violate the act. So all the records, including Form F, your referral slip, your consent forms must be preserved for at least 2 years. And if you are undergoing any legal proceedings, it should be preserved until the that legal proceeding has completed. Next. Section 4, clause 3 is a presumption of guilt clause where the act contains a presumption of guilt clause in any deficiency in record is presumed to indicate sex determination unless proven otherwise. So the burden to prove your innocence is on your shoulder. Next. What are the penalties and punishment which is described in section 23? So if it is a first offense, there is imprisonment up to 3 years and with harsher punishment if the repeated offense has been noted, and medical registration may be suspended or permanently cancelled, which I will describe in the next few slides. Like for first offense, up to 3 years of the imprisonment with a fine of 10,000, and if another offense, 50,000 is the fine and 5 years the imprisonment. First offense, upon framing of the charge, not if you are even if you are not going guilty, you are not going you are found guilty, or if your case is still going on in the court and the charge has been framed, the gynecologist registration with your state medical council may be suspended until the disposal of the case. And if you found convicted, the name is removed from the register for 5 years if it is your first offense, and if subsequent offense, permanently they can remove your name from the registry, and your machine is seized and sealed in each and every case. So understand, these offenses are the cognizable, non-bailable, and non-compoundable. What is the meaning of cognizable? Do you know what are the offenses in Indian Penal Code who are cognizable? Murder, rape, dowry death, then attempt to murder. These are the act which are cognizable. Like PCPNDT Act is also cognizable. It is non-bailable. In these cases, police can register FIR, start the investigation without the permission of the court. Police can arrest you without the warrant, and it is also non-compoundable. What is the meaning of non-compoundable? Non-compoundable means the complainant and the accused cannot settle down or withdraw the case out of the court. So even if the district health authority frame charges against you, your case is in the court, you and the district authority cannot settle down you have to pass through the proceeding of the court, and honorable court is the only place from where you will get either judgment or the punishment. You cannot settle down your case on your own. Next. So after knowing all these things, what is the role of the gynecologist? So we are doing practice ethically, but we should firmly refuse the sex determination request. We should ensure the documentation are proper. We should train our staff, and we should do regular audits to ensure the compliance of this whole process. Next. Any advertisement is strictly prohibited. Next. Whether it is in social media or hoardings or wherever. And what is the view of the Supreme Court on PCPNDT? Sometimes we are going to the health ministers that you are doing wrong with the gynecologists. This PCPNDT Act or its clause are very strict for us. We cannot maintain all those things. The view of Supreme Court is that it repeatedly emphasized that strict implementation of this act should be done. Why? Because holding the medical professional to a higher standard of accountability to protect the girl child. So it is our accountability to follow the act according to the Supreme Court. Next. We must know what are the regulatory bodies starting from the center to the state to the district. There are two main bodies at the central level. One is supervisory body and one is advisor body. The same thing at the state level, one is supervisor body and one is state advisor body, which advise, form the law and give the responsibility to the implementing body, which is either state appropriate authority or district appropriate authority or sub-district appropriate authority. Normally, we encounter our connection with either sub-district appropriate authority body or district appropriate authority body. And these people are conducting 3 monthly seminars. So we have to attend that seminars and we must know what new things are implementing in this all PCPNDT Act by the advisory board or the supervisory board. Next. And what is the function of this appropriate authority? To grant and suspend or cancel the registration of any clinic, genetic clinic or any hospital or lab, to investigate the complaint, to create public awareness, to take action on the recommendation of the advisory committee, to take appropriate legal action against the use of sex selection technique, to supervise the implementation of provision of the act and rules, and to recommend the upper boards to modification required in rules in accordance with the change in technology and social conditions. Next. We must know the procedure of registration before starting our clinic, submission of Form A, which is in duplicate form to appropriate authority. Two affidavits should be there. One is to undertaking that clinic shall not conduct any test or procedure for the sex determination. Another affidavit undertaking that the center and clinic is prominently display signage for no sex determination, and particularly the model of the USG machine, the name of and qualification of the particular person who is going to perform the sonography, and experience certificate should be attached. Next. This is all in the first form, Form A, which is for the application of the registration or the renewal. There are so many forms. We knew only A and F. F is for the maintenance of the records in respect of the pregnant woman by ultrasonography. These are another form, Form B, which we are getting certificate of registration. Form C, if you are been rejected, the Form C they will give you. Form D is a maintenance of record by the genetic counseling clinic. Form E for the maintenance of record by the laboratory. Form G for the invasive techniques, and Form H, which is for the maintenance of the permanent record of the application for grant or rejection of the registration. These all are the form. We mainly knew about the A, B, and F. Next. And what is the common myth amongst all the obstetricians? That the act does not excuse the ignorance or procedural lapse. Any common misconception include belief that only radiologists are liable. No, we all are liable. Our staff is liable. Our clinic is liable. Our hospital administrator is also liable. And daily completion of F form, proper display of notice, staff sensitization, regular audits, and prompt response to notice from the authorities are essential, because if they are giving 7 days of time to reply, and if you are not going to give reply in 7 days with proper advice of the medical legal consultant, you may got caught and you may be considered as a person who is violating the PCPNDT Act, and you have to enter in the court. Next. So what is our responsibility? Primarily, no sex selection process should be performed at our center. Strictly follow the registration process. Meticulously maintain all the record, particularly Form F record. Submit that Form F in time. Informed consent should be taken from the patient before conducting any ultrasonography or any prenatal diagnostic procedure, and limit the use of the USC. As Dr. Malhotra sir says, 5 times must we have to do ultrasonography in antenatal period. Next, one case study is that one private clinic in a semi-urban district which found that incomplete Form F documentation, though there was no direct disclosure of the fetal sex, the F form was not completely filled. When the district appropriate authority visited and inspected that particular clinic, and they found that there are repeated referral of this woman who later underwent the MTP elsewhere. So 3 or 4 ultrasonography has been done on the same patient. Form F was not filled completely. Decoy operation was done by the authorities, and clinic sealed, radiology suspended, and legal proceedings lasting for 8 years. So what is the key message? Most PCPNDT violation occurs due to the documentation lapse, not intent, but the punishment is the same. So this is the district appropriate authority investigated a radiologist center. The pregnant woman underwent MTP elsewhere, but the history was telling that she underwent ultrasonography repeated times, different centers, and this particular radiologist found that filling the F form incompletely, and she caught. Next. So we have to be vigilant in each and every step of ultrasonography while filling the form with the registration and everything. Once you got the notice, what to do? Before that, regular training sessions for doctors and staff, which help by this district appropriate authority, which are doing regularly. And upon receiving a notice, immediate legal consultation with your nearby medical legal consultant should be done. You have to preserve all the records. Please don't get panic and destroy the record. Keep whatever the records you are having, even if though you are having the incomplete F form, keep it like that. Don't destroy the record because it can worsen the legal consequences. Next. So what is the key take home message from that? This is the act which is very stringent but manageable, with knowledge, ethical intent, systemic compliance. We, the gynecologists, can practice confidently while contributing to the larger goal of protecting the girl child. Thank you very much for the patient listening. And next slide for with folded hands. I need your support. The nomination form will come in May and the election will be in August. Please nominate me from your society, and in August vote for me. I'm contesting for the Ethics and Medical Legal Committee of FOXI, election year 2026. Dr. Sarfaraz Qazi. Thank you very much.
Thank you, sir. Thank you so much, Dr. Qazi, for this extremely insightful, informative presentation. What we actually, हम obstetricians को पता होना चाहिए. जैसे बोला कि we can't get away saying कि हमें पता नहीं था. That the knowledge of the law is not there with us. We are supposed to know. I
just want to take one more minute. Yesterday, I am a president of my society. So one of the newer gynecologist who is not still get his registration. He was working in one clinic. He got caught by the district appropriate authority while doing ultrasonography. He is not having his registration under the GMC right now under Gujarat Medical Council. Both has been given notice. This young fellow also and the clinic owner also. And I think we are praying for that all the documentation they will provide properly and they will go through this case. So yesterday, he visited me.
So yes, so these are very important points that you've highlighted, sir. So thank you so much. We now will invite our esteemed chairpersons to kindly share their comments. And Dr. Professor Khan, ma'am, we introduced you, but as you have just written, you were busy. You are unable to unmute. Ma'am, now, respected ma'am, we want your comments. Thank you, ma'am, for joining.
Good evening, everybody. Thank you so much, and I'm extremely sorry. But I had informed both Dr. Sarfraz and Dr. Deepika that I have another meeting which will be finishing by
Yes,
4, but
ma'am.
it was extended for some time, so I could not respond at that time, though I did
Yes.
see my CV being read. So I think the PCP and DT Act, the topic is very appropriate and very appropriately covered by Dr. Sarfraz. It gives us a framework for preventing gender inequality and female feticide, and it emphasizes on ethical use of technology. And Dr. Sarfraz has covered it very nicely, starting with history, the legal framework, the registration process. Here, I would like to add that if you're performing any procedure, then you have to add that part in the registration itself. So earlier, if your facility was registered just for sonography, you have to get it added that you will be doing an amniocentesis or a chorionic villus biopsy. Then also we talked about the documentation and the very important loopholes that can be there, that can be misinterpreted, that you are not doing your work properly or you have some ulterior motive in mind. And then, of course, he added some personal experiences which made his talk very interesting, the penalties, etc. So I think it is our own responsibility, each and every one of us, that we collectively reinforce the compliance of this act and move towards a more, equitable society where there is no female feticide and women are empowered and treated as equal as men. So thank you very much,
Thank you
and
very
wish
much.
you all the very best, Dr. Sarfraz.
Thank you very much, Tamkin ma'am. Though you told us that you are busy and still you are here with us on this webinar, that's a great commitment from your side. That shows your commitment. Thank you very much.
Thank you, ma'am. So may I now request Dr. Manju Prabhakar ma'am to please give her comments. Is she there? I think I can't see her on the sir, dikh rahe? I don't
नहीं
think
नहीं
ma'am is there.
मंजू मैम जस्ट
Dr. Vidya Chaudhary
अभी
ma'am.
लॉग आउट हुई.
हाँ, Dr. Vidya Chaudhary ma'am, would you like to comment? I can't. I think she's
She's
muted.
there, but
Yeah.
she's muted.
हाँ.
It's okay.
Okay.
No problem.
And Dr. Neeru Thakral ma'am. So I think they're not Dr. Neeru Thakral, I can't see. So I think, sir, with your permission, can we go on to the next scientific session?
Yes,
Okay.
yes.
Yeah. So we now close our first scientific session, and we sincerely thank you, sir, for your excellent presentation. And
Thank you very
we
much.
thank all our respected chairpersons for their valuable insights and guidance. And especially Dr. Tamkin ma'am, she had she had messaged me, but yet she took the trouble of joining. So thank you so much, ma'am. Now we start with our second session. And our speaker for this session is none other than Dr. Bela Bhatt ma'am, who will be speaking on the topic of anomalies at nuchal scan and counseling. But before inviting ma'am, it is my privilege to introduce our distinguished chairpersons for the session. So I will introduce Dr. Bharti Maheshwari, though ma'am has got an emergency, so she has already given us her blessings. But a short introduction for Dr. Bharti Maheshwari, who was our chairperson for this session. Ma'am is the professor and head of department Obs and Gynae and IVF at Muzaffarnagar Medical College, and she is currently the president of Meerut Obs and Gynae Society and also the president of Meerut ISOPAR and Meerut Menopause Society. So ma'am was in one emergency surgery, so she has already given us her blessings. So we move on next to, can we have the next? Yeah. We have our Dr. Ritu Khanna ma'am, who is our next chairperson. We welcome you, ma'am. Ma'am is the director of Khanna Medical Center and Fertility Clinic. Ma'am is a fertility specialist and eminent endoscopic surgeon. Ma'am is served as chairperson of FOGSI Food and Drugs and Medical Surgical Equipment Committee and is currently the National Vice President of Indian Fertility Society and is also the Governing Council member of the ICOG. We welcome you, ma'am, and thank you, for chairing this session.
Thank you, Deepika. Thank you so much.
Our next chairperson is Dr. Saroj Kumar ma'am. Ma'am is the president of Gurgaon Obs and Gynae Society and is a highly respected senior member of our fraternity. Ma'am brings with us many years of rich clinical and academic experience. and is widely admired for her contributions. I don't think
We can't hear you, ma'am.
Hello.
of Dhanvantri Super Speciality Hospital at Moradabad. Ma'am is certified by the Fetal Medicine Foundation UK and has numerous papers and posters in a presentation at regional and national conferences. So with this eminent panel of chairpersons guiding our session, we request Dr. Ritu Khanna ma'am to kindly introduce our respected speaker for the session, who's none other than Dr. Bela Bhatt ma'am. And we really thank Dr. Bela Bhatt ma'am. आपके जितनी बार भी सुने कम नहीं होता. We always get to learn something new from your presentation. We wait eagerly to hear your presentation. Dr. Ritu ma'am, please introduce ma'am formally. Thank you, ma'am.
Myself, yeah. Thank you so much. And I think it's an honor to introduce Dr. Bela Bhatt, a very, very good friend of mine, and we've been working together for a long time. She is the consultant, Dr. Bela Women's Hospital and Fetal Medicine Center, Mumbai. She is the Vice President-elect FOXI 2027 and Chairperson FOXI Imaging Science Committee from 21 to 24. Fetal Medicine Consultant, Dr. Baba Saheb Ambedkar Memorial Central Railway Hospital, Mumbai. And she's achiever of so many awards, the CS Dawn Award. FOXI has talent, and we witnessed her in the North Zone that we had held over here in Varanasi. And FOXI Superstar, FOXI Dhira Award, FOXI Badlav. And I think lots and lots to, applauds to her. So welcome to you, Dr. Bela Bhatt, for your anomalies in the nuchal.
Thank you so much, dear.
Before starting your talk, I just want to add one thing. Bela ma'am is a so grounded personality that you can call her anytime, and she was answering you so with all the smile and so softly that
we are all friends. We are all friends, so
yeah.
no formality for sure. Thank you so much.
Please, we wait your talk.
Thank you so much. First of all, dear Ritu, thank you so much for those kind words of introduction. We have been very good friends and we have worked together for 3 years in FOXI as chairperson. So we cannot forget that golden period.
Fantastic time.
We worked together. Yes. And of course, when we came to Varanasi, there was another experience. At the outset, first of all, let me thank Dr. Sarfaraz Qazi and Dr. Deepika for making me part of this wonderful webinar series of Well Women webinar. And I must also congratulate both of you for continuing for such a long time. Last year also you did so many webinars, and this year this is 11th episode. So congratulations to both of you. And Dr. Sarfaraz, all the very best for all your endeavors in FOXI in coming years. So with this, I'll just share my screen. Give me a second.
Yes.
I'll make it a full screen first. Entire screen. Okay. Yes. Okay. Hope this is seen now.
Yes, ma'am.
Okay. Yeah.
Yes.
Fine. So, okay. Okay. So the topic that has been given to me is first trimester anomaly scan and counseling. Please excuse me in between because I also have got a little bad sore throat. Well, we all know that these days, as our stalwarts, Dr. Usha Madam, Chandravati Madam, NM Sir, all mentioned that the first trimester scan, that is nuchal scan, which is done from 11 to 13 weeks, 6 days, is very, very crucial because of this inversion of pyramid, in which we know that right at nuchal scan, we are going to segregate our patients based on the nuchal scan and double marker. We can segregate our patients into low risk and high risk and completely plan the management of pregnancy from 12 weeks to 40 weeks. And the three important arms of this nuchal scan are, of course, the risk calculation for common chromosomal problems. Second is anomaly detection, and the third one is risk calculation for preeclampsia. Now, out of this, we all know that the incidence of Down syndrome is 1 in 800, but that of anomaly is 3 to 5 per 100, and we all encounter this in our daily practice, and therefore we must know about it. And nowadays, why there is so much of importance given to this nuchal scan? Because in the last decade, with higher resolution machine, better skill, we can pick up so many anomalies right at the nuchal scan. And these are some of the 9 always detectable anomalies. I'm not going to enlist it because we are going to go through so many cases that I'm going to show. Now, the basic concepts for, this talk is for both those who are already doing ultrasound or those who want to interpret and counsel the patient. So, the basic concept is when you are doing the first trimester scan, you must know what is normal, and then only you'll be able to pick up as to what is abnormal. This is the basic principles of medicine, and therefore we shall always compare normal with abnormal. Now, to begin with any scan, the first thing that we look at is the cardiac activity, so that the patient is also sure that my baby is fine, and we start a scan on a viable fetus. Now, for nuchal scan, we all know that the most crucial dissections are, number one, the image that we have to take in midset section, CRL, and the NT-NB. These are 2 very, very crucial images. And when we are trying to acquire these sections, that itself can rule out so many structural defects in the fetus. So here I have shown the sagittal and the axial sweep that we take at nuchal scan between 12 to 14 weeks. And we can look at, in the midset section, we can look at the intact cranium, intact anti-abdominal wall, ductus venosus, stomach, diaphragm, bladder in the same go, in just when we are trying to look at the CRL. So let's see what abnormalities we can pick up in this. So when we have acrania, that is a defect in the cranial vault. So there may or may not be exencephaly, but here you can very well see there is acrania with exencephaly. Here another case. So these are some of the gross anomalies that nobody should and nobody can not pick it. So body struck anomaly is another gross anomaly which you'll always pick up when we are trying to take the CRL section at nuchal scan. Now, obviously, these are the gross anomalies that the patient would want us to terminate. But as I go through the presentation, I'll just show how important it is for us to try and reach to the cause of each anomaly. So this particular patient, 12 weeks, 5 days pregnancy, non-consanguineous marriage at the age of 33 years, third gravida, previous one missed abortion, 1 female alive, Rh positive, and on ultrasound, as you can see, there was subcutaneous edema. There is also pleural effusion. So we know that when there is fluid in 2 cavities, this is hydrops fetalis, and the heart was normal, but there is significant subcutaneous edema you can see here, and this patient also didn't want to continue. So we have 2 options, either go for CVS or on the fetus, we can do the genetic testing. And this particular patient, also when we did the genetic testing, it did show trisomy 21 on this. So now, why is it important to find out the cause? Because the minute you find out the cause, you know how to counsel the patient for the next pregnancy, because there are genetic conditions with 1% recurrent cause. There are some genetic conditions like autosomal recessive or autosomal dominant condition where there would be 25 to 50% chance of recurrence in next pregnancy. So it's very, very crucial for us to try and join the dots, to try and reach to the cause, and then we'll be able to counsel the patient in this as well as next pregnancy. Now, in the same CRL section, we can also see a tiny bladder. Most of the time, when we are doing the nuchal scan, and it's important to document presence of bladder, whether it is seen or not. Kidneys, renal arteries, and two umbilical artery which are flanking the bladder are all part and parcel of the first trimester anomaly scan. And here you can see that the first one is the proper two umbilical artery, and in the other clip you can see only single umbilical artery. And whenever you see there is only single umbilical artery, we need to again look at all the detailed structures of the fetus and whether there is any other cardiac or GI, GU or any sort of anomaly, because then the entire prognosis and the workup of a case changes. So in this particular case, you can see there is a single umbilical artery, as you can see on the clip, but along with that, you can see that there is subcutaneous edema. You can see jugular sacs, you can see the ascites and collection of fluid. And so this is again, we know there are other findings, micrognathia, as you can see that there is cardiac anomaly, there is AVSD with tricuspid regurgitation with reversal of A-wave on ductus. So we know that when there are so many structural anomalies, structural markers along with a single umbilical artery, the chances that the fetus has some genetic cause increases greatly. And therefore, even if the patient wants to terminate the pregnancy, number one, we can either do CVS and do the test, genetic test, or after termination, you can send the fetal tissue for the genetic test, that is microarray and DNA storage, or you have the third option, because many of the times the obstetricians argue that the patient are not ready for genetic testing because it's very costly. So we have an option here. We can send the fetal tissue for DNA storage in a genetic lab that stores this DNA at the cost of just 2,500 for 2 years. And later on, after 3 months, after 6 months, when the patient is mentally and financially ready to test, you can do the genetic test, because as I know, it has implications on the next pregnancy and it will help your patient a lot. Otherwise, we'll be clueless in next pregnancy. So this is something which is very, very important. And unless and until an obstetrician counsels the patient is not going to do genetic testing. Then we always look, as I said, we look at the bladder. So what is megacystis? When the longitudinal diameter of the bladder is more than 7 millimeters, it is called megacystis. And you can see in this particular clip, there is very obvious megacystis. And here you can see in the clip also that this bladder is flanked by 2 umbilical arteries. So it is not another cyst, but it is a enlarged bladder. And therefore, when there is such a gross dilatation, whenever the diameter is more than 15 millimeters, we know that the cause is rather obstructive cause. Whenever it is between 7 to 15 millimeters, the chances of chromosomal problem is 20%. But when it is more than 15 millimeters diameters, like in this case, there are more chances that there is an obstructive cause like lower urinary tract obstruction, which has led to megacystis. And not only that, you can see here both the kidneys are also showing these plastic changes, and therefore when so early in the pregnancy at 12 weeks there is an obstructive cause, the prognosis is generally poor, and its patient would not like to continue because the surgery postnatally also wouldn't help much in such patients. Now, this particular patient was third gravida 2 para, where there was a history of 2 LSCS, and both the kids had died 3 to 4 days after birth, but the details were not available. There was history of one affected child with some kind of neuromuscular disorder on maternal child side. Again, the papers were not available. Now, this particular pregnancy, they had These were the findings on nuchal scan. You can see there is fixed flexion in the upper limb and lower limb, and also there is subcutaneous edema. So we can see there was fluid collection in the cavity. So hydrops with fixed flexion deformities upper and lower limb. So we know there has to be some neuromuscular disorder, and we know the history that the previous 2 kids also have died because of some neuromuscular disorder, where they gave history the baby had fixed contractures. So this time what was counseled to the patient was that patient was referred to me from a government hospital. So patient was counseled that even if you terminate this pregnancy, it's very, very important that at least in this pregnancy, we do the genetic testing on the terminated abortus, so that we come to know about the cause. And in such cases, we need to do a trioexome sequencing. That is, you test the fetus or the abortus and also both the parents, because we have to find out whether the parents are carrier. So in this particular case, as you can see, that when trioexome sequencing was done, the fetus was showing abnormal COSY-related disease mutation in homozygous state. That means fetus was affected by arthrogryposis, and both the parents had the same mutation in heterozygous state. That means both the parents were carriers. So this is important to establish. Now we know that for all the 3 pregnancies, this was the cause for the arthrogryposis, and therefore now we have mutation in hand, and next pregnancy we can test after chorion villus sampling at 3 months whether the fetus is affected or not. And in the next pregnancy, the patient came to me from early pregnancy. At 12 weeks, I performed nuchal scan, which was low risk, and then chorion villus sampling was performed, and on that it was tested whether the same mutation this fetus is carrying or not. And fortunately, this time fetus was not carrying the same mutation, and so the fetus was not affected. The patient continued the pregnancy and at term delivered a female of 2.5 kg, that is 4th pregnancy, and so a healthy child. But this, they could be very sure right at 12 weeks, because we had mutation done pre-pregnancy. So it's very, very important to test for genetic cause or mutation pre-pregnancy. Whenever you have some kind of anomaly in the fetus, in the same pregnancy, if you test, you'll be able to help in the next pregnancy. Otherwise, again, we'll have no clue. So in this particular pregnancy, in the 3rd pregnancy, because we had tested and we had mutation in hand, in 4th pregnancy, we could help at nuchal scan, and patient continued till term and delivered healthy baby. Now, when we look at the nuchal scan, as I said, the sagittal section of the head, the axial and coronal are extremely important for the NT&B image, in which we look at so many structures in the brain as well. So here, as you can see, very, very important surrogate sign or a cranial sign of neural tube defect is the BS and BSOB ratio. So BS is brainstem, and brainstem to occipital bone ratio should always be less than 1. Whenever it is more than 1, that shows that the hindbrain is pulled down, and therefore the BS to BSOB ratio is more than 1. In this particular case also, as you can see here, there was a open neural tube defect. When I looked at the spine, you can see the spine opening up there in the lumbar region, and therefore this was a open neural tube defect with secondary signs in the brain. So this was an Arnold-Chiari malformation, and that is also something with the secondary signs. We'll look at the spine carefully and to find out any kind of neural tube defect. In the axial section, we must always see this beautiful butterfly of the choroid plexus, and when we do not find it, we must anticipate some kind of cranial, the brain anomaly. And we can also look at the coronal section of the face, with the orbits, premaxillary triangle, and mandibular gap, which also rules out some of the conditions like the micrognathia, cleft palate, etc. Now, this particular was a case in which not just absent nasal bone, but complete nose was absent. Now, this is, we can see in the midset section of the NT and B image, the nose is absent here completely. Baby also had the holoprosencephaly, and this had a arrhynia. So it was arrhynia, and as you can see with cyclopia, and this obviously patient didn't want to continue this pregnancy, but we did test the fetus and it did turn out to be trisomy 13. So again, establishing cause is very important to counsel the patient and counsel the patient in the next pregnancy as well. Now, this is a case which at nuchal scan you can very well see here that I do not see the stomach in the abdominal section. We must see a stomach bubble in AC section, which I can't see. And in this section, you can see this is the heart, which is pushed to the right by the stomach on left side. This is the left side and stomach bubble is here and some intestine, and it is pushing the heart to the right. So we can see, and in the longitudinal section also, you can see that there is a defect in the diaphragm. The stomach has gone into the chest and it is pushing the heart to the right. So this is a case of diaphragmatic hernia. Again, when the diaphragmatic hernia with herniation of contents occurs earlier in the pregnancy, there is going to be more compression on the contralateral lung, and therefore the prognosis is likely to be poorer than when it occurs later. This particular patient, 29 years old, non-consanguineous marriage, third gravida, one female of 2.5 years and one abortion. Now, this is very, very interesting recent case. Now, this particular case, this patient was extremely obese with previous one section. So the resolution was not good. I tried doing transvaginal also, but because of the previous section, the uterus was stuck to the abdominal wall. So I didn't get good section, but something was not good on these sections. And that was, the head was looking bigger than the abdomen. There on CRL, when I looked at the CRL, dating was perfect because the patient had one 8-week scan, which was showing good CRL. And so I had a good dating scan. And now when I took the CRL, it was going less than 1 centile. So with proper dating, when the CRL is less than 1 centile, I know that this is early onset asymmetric FGR. The AC upon HC was 1.5. And therefore we know that this is asymmetric FGR with like a subjectively less with thin placenta. So I was thinking about either it could be triploidy, digyneic triploidy, or trisomy 18, because these are the conditions which have very early fetal growth restriction, which is can be picked up at nuchal scan. And the double markers also were very, very low, 0.07, 0.05. So everything added to my suspicion of triploidy. And after that, the patient was counseled, but it was just 12 weeks. So they wanted to wait and see if the baby is growing. Obviously, the patient feels there is no other marker. They waited for a week or two and came back, and it was asymmetric IUGR. They wanted to terminate, but as I counseled them that the fetal tissue testing is extremely important because that will help them for prognostication in next pregnancy. And the POC was sent for microarray, and it did confirm triploidy. Not only that, it confirmed digyneic triploidy. So this is the significance of working up the case and finding the cause, because whether it will be recurrent in next pregnancy or not, we can come to know only if we have done this. And we know that triploidy is not something which will recur in next pregnancy, which reassures the patient a lot. Cardiac evaluation is also something that we do. We look at the situs, we look at the inflows, outflow, and crossing over of great arteries. And there are also the ductus venosus and tricuspid flow. If there is an abnormality, it points towards the cardiac anomaly. There are some markers that we find on a nuchal scan, like increased nuchal translucency, tricuspid regurgitation, and A-wave reversal, which are the markers of CHD, that is congenital heart disease. We have to look at the heart very, very carefully when we have these markers. Just one case I'll explain here, 25 years old, primary gravid. As you can see, there is hydrops with, you can see gross collection in the subcutaneous tissue as well as in the pleural and peritoneal cavity. And not only that, there was AVSD, cardiac anomaly with reversal of A wave in ductus venosus. So hydrops with cardiac anomaly, and again the patient. So these are markers of CHD that you can see at nuchal scan. And again, the patient didn't want to continue, and the abortus genetic tissue was sent for microarray, which showed Turner syndrome. So you can come to know about so many anomalies and the causes right at 3 months and counsel the patient very well. As I said, you can look at the kidneys, the renal arteries. We always look at the upper and lower limbs. 3 segments have to be documented, and it's easier to look at them at nuchal scan. And this is even easier sometimes than at anomaly scan. Upper limb, lower limb, both documentation is extremely important. This particular case, I could see polydactyly at nuchal scan, and then I didn't find any other abnormality, but I called a little early for anomaly scan. And at 17 weeks, I could see multicystic dysplastic kidneys, and there was almost no Liker at 17 weeks. With this, there was no CNS anomaly, however, so Meckel-Gruber could not be established, but patient, because this is a lethal anomaly, patient obviously wanted to terminate. The DNA was stored, but then the patient didn't want the genetic testing further. But then this is important to counsel and try and reach to the cause. Spine also we can look at nuchal scan, and we can find out so many spinal anomalies right at nuchal scan. Another case of open spina bifida that you can see in both the sagittal and the axial section. Another case of spinal kyphosis, sacrococcygeal cystic teratoma. So this can go on and on and on and on, because there's so many anomalies that we can pick up. Now, the benefit of picking up anomalies at nuchal scan is that if it is a lethal anomaly, or if it is an anomaly where there'll be severe handicap, it allows for earlier and safer termination, less risk to mother. We all know termination is safer at 12 weeks as compared to second trimester, and favorable cost-benefit ratio as well. They can protect their privacy. Another benefit is, even if they want to continue, suppose there is a exophthalmos, we have ruled out genetic cause, and prognosis is good, they want to continue. It gives them time to prepare for the postnatal treatment, where to deliver, finances, everything can be planned very well, and we can monitor till term these fetuses and give the best result to them. We are not here just to pick up the abnormalities. So, in cases where patient is diabetic or patient is on anti-epileptic drugs, previous history of any anomaly, if we can rule out some of the common anomalies at nuchal scan, the reassurance of normality in early pregnancy is also very, very, gives a feel-good feeling to the patient. But I'll also show the limitation of this. The other benefit is that obese women or with previous abdominal scars, many a times by doing TVS, we can look at the anomaly beautifully, which is not possible in the second trimester anomaly scan. So these are the benefits. But we must also remember there are limitations of first trimester anomaly scan, and some of the anomalies are never detected at nuchal scan, like macrocephaly, cerebellar abnormalities, agenesis of corpus callosum, achondroplasia, pulmonary sequestration, CCM, bowel obstruction, and some more. And therefore, we must not tell the patient that we have ruled out all anomalies. No. The first trimester anomaly scan is not a substitute for the second trimester anomaly scan, but it just adds information and picks up some of the gross anomalies right at nuchal scan. But patient has to be told that rest 80 to 90% anomalies will be able to pick up at your 18 to 20 week scan, and therefore that scan is mandatory and not that we have ruled out all anomalies. So this is the medical legal significance, because if you have told that there is nothing wrong and it's some anomaly comes up at second trimester, you'll be held responsible that you said everything is normal and how come there is some anomaly now. So it's always better to tell them the fetus has not yet developed well. It will develop well. We can see almost 80 to 90% structures at second trimester anomaly scan, and therefore we must do a second trimester anomaly scan as well. But as I said, there are 9 always detectable anomalies, and those anomalies should never ever be missed at first trimester anomaly scan. I have already discussed many of them, so I'm not going to repeat them, but these are some of the gross anomalies that we will not miss, and we will help our patient a lot by early detection of these anomalies and counseling them well, so that they are very well prepared for the delivery and planning the delivery, etc. Thank you so much for your patient hearing. Thank you.
Thank you. Thank you, Dr. Bela. I think that was a fantastic presentation. I think we always keep priming our patients right from the beginning. They come to us that they shouldn't miss this time, because once they missed it, they missed something very, very crucial. And because this is the time you're going to look at the fetus with an eagle's eye. And with your combined test, detection is almost 90-95%. And it allows all the parents to really plan, what they're going to do further. And thank you so much to Dr. Sarfaraz, very, very dynamic, and for inviting me to this Well Women series. I think it's one of the well-run series, and it's always pleasure to be here to have so much of knowledge. Your topics, your speakers, I think it's excellent, and that's all your efficiency. And thank you so much, Deepika, for taking us all the way through and so patiently with us. And Dr. Sarfaraz, wishing you all the best for all your future endeavors, and I'm sure that you're going to do very well with it. Thank
Thank you very much, ma'am. Thank you very much for
Hi,
your
Dr. Bela.
nice
I
words.
am here, Dr. Bharti. I
Yes,
came from my
ma'am.
emergency.
Thank-
So I
Thanks,
have heard
ma'am.
your lecture, yeah. So it was very good, and we all know that the Dr. Bela's lecture that we all obstetrician have these all basic informations, and we are nowadays most of us are trying to diagnose all congenital anomalies earliest, so that we can do justice with the patients. And it's very informative. And congratulations, Bela, and thank you, Deepika. So nice to see you, and of course, best wishes to Dr. Sarfraz. Thank you very much.
Thank you, Bharti ma'am. Thank you very much for coming all through the OT. And Vila ma'am, it was a excellent videos and images to understand for routine gynecologist also. As usual, you are creating a very much accessible and understandable for the routine gynecologist, so that we people can understand from where we have to diagnose which anomaly and which is the view that we have to concentrate. Thank you very much. Thank you very much. Excellent presentation, ma'am.
Okay. And hi, Dr. Ritu. Nice to see you. And nice to see you, all my colleagues from Muradabad and different places I can see. So well organized, Dr. Sarfraz and Dr. Deepika.
Thank
you again,
Congratulations.
ma'am.
Thank you, ma'am. Thank you, ma'am. And I think, sir, Dr. Dipali and Dr.
Dipali ma'am
are
is in
not,
OT. हाँ,
they are busy, so they are not
yeah.
there. And Dr. Bela, ma'am, thank you so much. Master class by master teacher. Actually,
Yes.
पूरा समझ में आ जाता है. And we every time you are taking so much pains and so much trouble in teaching us, who are the core obs and gynae, हमारे अल्ट्रासोनोलॉजिस्ट करते हैं, so हमें interpretation करना आना चाहिए. That is important. Lots of people, our ultrasounds are being done, so we get to know, okay, which are the good ultrasonologists, which are the good level of scans, and which are not, and what should be the difference. Thank you, ma'am. Thank you so much.
Thank you so much, Dr. Deepika, Dr. Sarfraz, Dr. Ritu,
Thank
Dr.
you.
Bharti, for those very, very kind words. And it's always pleasure amongst to be there.
Bye,
with all
Bela.
of
So
your
nice
friends.
to see you. Even your
Same here.
background, it is so pretty. Green and
All
you
green.
and all.
Hi, Dr. Subbu is also there.
Hi, good talk.
Thank you so much. So it's always good to connect. Thank you, Sarfraz, for connecting all dear friends.
Thank you. Thank you, ma'am. It's a pleasure, ma'am.
Thank you so much.
Thank you.
Thank you very much, ma'am.
Dr. Sarfraz has been the nucleus amongst sub seniors, juniors, sub
So
nucleus.
true, so true, so true.
Thank you, sir. Thank you.
Hopefully, I will remain like this.
Yes,
Yes,
you will
sir, definitely.
always.
That's what we want. All best wishes.
Thank you.
So thank you very much, ma'am. Sir, with your permission, can we go on to the next session?
Yeah, for
discussion?
panel, yeah.
Yeah. So thank you so much. Now we move on to our third session, which is the panel discussion. And the topic of the panel is from detection to decision, navigating the second trimester fetal anomalies. And our esteemed moderator for the session is Dr. Divya Singh, madam. Ma'am is from PGI Chandigarh, and she's a consultant radiologist at Mirkais Diagnostic Center, Chandigarh, and the chair of ISWAG Digital Learning Subcommittee. We welcome you, ma'am, as our moderator, and we look forward to a very, very insightful panel discussion where we have already talked about the first trimester abnormalities, ultrasound, and now ma'am will be teaching us about the second trimester abnormalities. And I quickly welcome Dr. Divya ma'am. So I quickly, go on to bringing our panelists on board. So can we have their, yeah. So our first panelist is Dr. Ila Kishore ma'am. Ma'am is the consultant, Orion Hospital and Maitri IVF Center. So we welcome you, ma'am. Then our next panelist, Dr. Vandana Gupta ma'am. Ma'am is the president of Katni Obs and Gynae Society and the founder, vice president of Katni Obs and Gynae Society. We welcome you, ma'am. Our next panelist is Dr. Anita Sharma ma'am. Ma'am is a senior consultant at Mangalam Hospital, Gurgaon, and is the president-elect of the Gurgaon Obs and Gynae Society. Welcome, ma'am. Dr. Nidhi Bansal ma'am. Madam is the secretary Agra Obs and Gynae Society, and also the secretary of Agra was the secretary of Agra Menopause Society. Dr. Nidhi ma'am, welcome. Our next panelist is Dr. Sumbul Nayam ma'am. Madam is the secretary of the Aligarh Obs and Gynae Society. The next please. We welcome Dr. Subui Rizvi ma'am. Madam is the director, Mothers Clinic and Ultrasound Center, Gurgaon. And ma'am, we welcome you. You are the vice president of the Gurgaon Obs and Gynae Society.
Thank you.
Thank you, ma'am, for joining. Then our next panelist is Dr. Nidhi Bajaj, ma'am. Ma'am is the director, Sparsh Multi-Speciality Hospital at Katni, and is the secretary of the Katni Obs and Gynae Society. We welcome you, ma'am. Our next panelist is Dr. Ashok Patel, sir. Sir is the director of Mamta Gynec Hospital and Research Institute at Idar at Gujarat. We welcome you, sir. Dr. Rakhi Malhotra, ma'am. Ma'am is a graduate from Bhopal and has fellowship in minimal invasive surgery, and is currently the director of Kilkari Hospital. We welcome you, ma'am. And our next panelist is Dr. Ruta Vicaria, ma'am. Ma'am is having a fetal medicine center and is the secretary of the Surat Obs and Gynae Society. And our next panelist is none other than Dr. Bhargav Patel, sir. Sir is a fetal medicine expert from Modasa. We welcome you, sir. So I think we have all our panelists on board and on the video. So we hand over to Dr. Divya Singh, ma'am. Please, ma'am, please take over now. Thank you, ma'am.
Before starting with Divya ma'am, I personally want to thank Divya ma'am. On one phone call, you agreed to come for the panel, and I met her in the last webinar where I was so impressed with her way of conducting the panel, and I promised her that I am going to invite you once in my webinar, and it comes the day. The stage is yours, Divya ma'am, please.
Thank you, sir, for the kind invitation, and thank you, Deepika ma'am, for the kind introduction. It is my privilege to be a part of this academic extravaganza, and my heartiest welcome to all the esteemed panelists. So I think I'll begin the panel with sharing my screen. Please let me know if my screen is visible, sir. So
Yes, it
what
is.
we will do in the next 30 minutes is go through some of the common abnormalities that we encounter in the second trimester, try to see if we can come, study the sonographic findings and come to a diagnosis based on the images provided, and then make some sense out of that diagnosis and use it to guide our management or how we counsel the patients. So, is my screen visible, sir?
Yes.
Yes, yes, yes.
So I'll be starting with the first case, and I will request Dr. Anita to please take up this case of Mrs. A 26-year-old primary gravida, who was scanned at 14 weeks. And if you could, ma'am, please discuss what you see in this image and what do you think of this ultrasound image?
And this is the fetus in sagittal view, which I am seeing on the screen. The upper limbs and the lower part of the fetus is okay, but the head, I cannot see the skull of the fetus. The facial features are not clear. So I think this is the absence of the skull bone. To me, it appears in this section, in this sagittal view. I will check it again on transfer section. What it is showing.
So I'm providing you a video clip of the same fetus, ma'am, and you have the axial section here, as you were asking, and this is the sagittal section in the clip. So you can have a look.
Yes, and the sagittal section.
This is the axial section. So this is all that we have.
Okay. In the sagittal section, it is the exposed brain tissue.
Yes.
Not bounded by the skull bone. And in the transverse section also, that the ideal butterfly image of the brain tissue is not visible.
That is correct. This is a normal section of the head at this point of time for comparison. And as ma'am has rightly pointed out, we cannot appreciate the normal skull contour as should have been seen at this time, and the normal intracranial components are not seen. So based on these findings, ma'am, what would be the diagnosis from your end?
This is anencephaly?
Yes.
Acrania.
Yes.
I think both, yes. I think both can be, it is anencephaly.
Right. So, as ma'am has rightly said, this is acrania anencephaly sequence. So, as the name suggests, it's a sequence. So, when we see it early on in pregnancy, say in the first trimester, it is termed as acrania, because at this point of time, there is just the skull bone which is missing, and we still see a lot of disorganized brain parenchyma. But as pregnancy proceeds into the second trimester, most of the brain gets liquefied, and then there is hardly any brain tissue left, and that is why we then call the term anencephaly, that is, we don't see the brain at all. And there is a very characteristic appearance of the face which is described with anencephaly, ma'am. Could you please?
Yes, it's the frog's face where the we see the orbits of the fetus at the topmost.
Yes, so typical frog-like appearance because the brain tissue is absent, so the head appears totally flat. We don't see the overlying calvarium and brain, and we just see the bulging eyeballs as seen in this picture. So if this lady were to come to you, ma'am, what would be your counseling to this patient?
Yes, as we know, acrania is a lethal anomaly and 100% terminal. So we will advise termination of pregnancy to the lady.
That is correct. That will offer the option of termination. And ma'am, would you like to counsel her something about the next pregnancy, same in terms of the risk of recurrence, or how is it something which can be prevented?
Though it is rarely, genetic component is very rare, but still 1 to 5% recurrence rate is there. So we must advise the patient to plan her next pregnancy and get an NT scan earlier in the next pregnancy also.
That is correct, ma'am. So if, as you rightly said, usually acrania is not associated with a genetic cause, and if this is an isolated finding and for the first time, we may not offer genetic testing upfront. But if it is something which is recurring or which is associated with abnormalities in the other systems, then of course genetic testing is an option. And besides offering the NT scan, is there any role of periconceptional folic acid, ma'am?
Yes, most of the neural anomalies or the spinal cord anomalies, they are associated with folic acid deficiency. So we always advise the patient intake of folic acid periconceptional before planning pregnancy as well as in early pregnancy in the dose of 5 milligram per day.
Correct. That is correct. So besides anencephaly, there is another thing which can present like this in the second trimester. And if Vandana ma'am, could you please take up this case? So this is.
Hello, I cannot talk right now. Please message me. Please
Are
message
you
me.
there,
I cannot
Vandana?
talk right now. I'm in a meeting. Okay.
If Vandana ma'am is not there, maybe Ruta?
Yes. It's so nice to see you.
Nice to see you too.
Unknown caller. So I think this seems to be large encephalocele, if I'm not wrong.
Yes, I'm going to play a clip for you. So the
Yeah,
face
I-
of the baby, which I just showed you, was actually not the face of the baby with acrania, but with this. So if you have a look at this
Okay.
video clip, what do
Okay.
you see?
So I see large protruding mass from the brain.
Yeah.
So this is the brain.
Yes.
But can you appreciate something?
Yeah.
The skull bones?
Yes. Yeah. Skull bones are there, and in the posterior aspect, there is a protruding mass.
Exactly. So this is a case of a large encephalocele.
Encephalocele.
And yes, so as rightly pointed out by Dr. Ruta, we see a large amount of brain tissue which is floating in the amniotic fluid. But what is interesting is that if you notice this, there is presence of skull bones. So these white structures that you see, these are the skull bones. And it's actually, as Ruta rightly pointed out, a large defect in the occipital skull. So these are the skull bones, and this is that large defect through which the encephalocele is protruding out. And so a large encephalocele should always be kept in mind in the differential diagnosis of an acrania. And why would it be important to differentiate an encephalocele from acrania, Dr. Ruta?
Because the management changes completely for both the things. And sometimes encephalocele is associated with syndromes also. So we have to look for other features also.
Absolutely.
Like Meckel.
That is correct. So encephalocele always makes us search the other systems more carefully for a syndromic association, unlike acrania. And that is why it's important to differentiate the two.
Yes.
Hello. Now, we are in an era where we've actually moved from detecting sonographic abnormalities in 11 weeks to before 11 weeks. And Dr. Ruta, are you aware of anything that can be done before 11 weeks to diagnose acrania?
Before 11 weeks.
Before, that is at the time when we look at fetal cardiac activity set around 8 to 9 weeks.
Yes. Yeah.
Alpha fetal.
No, the image, this image, does this image give a clue?
Yes.
Ma'am, would somebody else like to take this
Yeah.
up?
Yes,
Please, ma'am.
we can always suspect acrania as early as 8 weeks, and we can have a 3D image also to see. But a confirmation at 11 to 12 weeks is a better thing. But suspicion can be there. Also, in cases of twins, you can see a sharp contrast in the echogenic in between the two amniotic fluid sacs also, and that can also lead to the suspicion of acrania at a very early age also, before you can actually see the cranial bone formations. So those two things are there. So even if in this you can see that the amniotic fluid it has those hyper-echogenic shadows here. So you can always call the patient again to confirm the diagnosis. But if you just leave the patient and tell them to come later on, say about 13 weeks, that would be too late. So in such cases, whenever I see early on, I call them early 11 weeks rather than calling them at 12 weeks or later. So between 11 to 12 weeks is a better call, but of course you can suspect from 8 weeks onwards.
May I, Dr. Divya?
Sure, ma'am,
May I
please.
add? At 8 to 9 weeks, we see the 3 vesicles in the upper part, no? The brain vesicles.
This is normal.
If we are not able to see these vesicular appearance, then we may suspect fetus having acrania.
That is correct, ma'am. Normally, in 2D ultrasound, we are able to see especially this large rhombencephalic
That is
vesicle
a
in all
normal thing.
fetuses after 8 weeks. That is why I've labeled it as control. And this was an embryo which was later proved to have acrania, and you can appreciate how the head totally lacks that rhombencephalic vesicle. And as ma'am has rightly said, this is the first clue. In addition, the amniotic fluid at times can appear to have a lot of echoes, as ma'am had rightly brought out. And this is what we mean by those echoes which are seen in the amniotic sac, though they were not seen in the embryo which I'm showing you at present. But this is how the amniotic fluid at times can look like in a baby with acrania. And absence of brain vesicles, and if you do a 3D ultrasound, this irregular contour of the surface of the cranial pole is a clue. And that is why, as ma'am has rightly said, we raise the red flag and ask these patients to come in the first trimester, because in our setting, sometimes people in low resources can end up missing the first trimester scan and land up with anencephaly in the second trimester, something which we absolutely don't want to see. And that is why we manage these patients proactively and encourage them to come as early as possible in the first trimester so as to confirm the diagnosis at NT scan. So thank you so much for your inputs.
Thank you.
And so we will move on to the next case. So Dr. Bhargav, would you like to take this case, please? Are you there, sir? Anybody else who would like to take up? Dr. Rakhi, would you like to take up this case, ma'am?
Okay. There is anechoic space in the front side of the brain. So it seems like there is a failure of division of forebrain. That is, we can't find falx cerebri in the front side of the brain. So, and the thalamus is likely seems to be fused. So the diagnosis may be holoprosencephaly.
Exactly, as ma'am has rightly brought out, this is an axial section of the brain at the level of the thalami, so what we call as the transthalamic view, and we have a normal brain for comparison here. So normally we should see what is known as this white midline, which is known as the falx cerebri, dividing the brain into 2 halves, which is totally not seen here. So this suggests that the brain is fused, and as ma'am has rightly said, when there is fused forebrain, what we think of is holoprosencephaly. Exactly. Anything else that catches your eye, ma'am, in between these 2 images?
Shape of the skull.
Shape of the cranium.
Exactly. Correct. This skull has this pointed kind of a shape because of craniosynostosis or premature fusion of the metopic suture, whereas here the skull has a normal rugby or a rugby football or an oval kind of appearance. So that is excellent. So in holoprosencephaly, ma'am, if you see such a finding in the brain, what is the next structure that you definitely train your attention to?
The face. The face.
Holoprosencephaly, it is also associated with midline facial defects, basically.
Correct.
So we have to look the face better in a better view, like in a sagittal or coronal view, to look for the defects of the face.
Correct. So that is correct. This line face predicts the brain has always been used in the context of holoprosencephaly. And why this happens? Why are there associated facial abnormalities with brain abnormalities?
Because there is a failure of division of the forebrain, so it is also associated with the face.
Yes,
face
because
symmetry
both
also.
have a common embryology, the face and the brain. So that is why when one thing is affected, there is usually a chance that the other thing would also have been affected. So that is perfectly correct, whatever we've discussed so far. And ma'am, how would you like to counsel if such a patient comes to you?
We would like to counsel that it is a lethal disease, so it's better to terminate the pregnancy And sometimes it is also associated with chromosomal abnormalities. So we should go for the genetic testing also. And sometimes it is also associated with like maternal diabetes or environmental factors. So we also should look for that also. And we should also go for detailed scanning also, detailed anomaly scanning.
Yes, that is correct. Ma'am, any chromosomal abnormality or common chromosomal abnormality that is associated with holoprosencephaly?
Trisomy 13 or
Exactly,
18.
trisomy 13. So whenever we think of holoprosencephaly, we specifically look for other features of trisomy 13 so as to exclude a syndromic etiology. And these are the various kind of facial appearances that can be associated with holoprosencephaly. You can see that there can be some very severe forms of facial defects with a single eye ball, which is known as cyclopia, along with presence of a snout, which is known as the proboscis, or there can be milder forms where you can just see a median cleft or a bilateral cleft lip and palate. There can also be a single nostril, which is termed as sebocephaly, or you can have something known as sebocephaly, that is a single nostril with autocephaly, when you see the ears low placed in the neck. Because remember, the external ears develop from the branchial arches. So this abnormality can be associated with failure of ascent of the pinna, and so you can have quite grotesque looking faces in these cases. And Rakhi ma'am, again, what would this case be, this image?
Image?
Sorry?
This one?
Yes, the
this
image
is
which you shared.
this is holoprosencephaly, partial holoprosencephaly.
This is again, yes, a case of a lobar but in the first trimester. So this is a younger brain, and as you have rightly said, there is no fox here. And this is that fused monoventricle or a single ventricle that we talk about in case of holoprosencephaly. So now, having discussed holoprosencephaly, we move on to another abnormality. And may I request who would like to take it up? Dr. Vandana, would you like to take this up?
Should I take it?
Sure, sure.
Okay. So we see the typical lemon sign here in this one, because you see the anterior frontal lobes, they are in the shape of the typical fusions that is there. And in the other image that I was seeing, yeah, this is the kind of lemon sign which we are seeing and seen particularly in the early second trimester also. Like it disappears after about some time, but then actually it's there, and then you can diagnose that there is something. You need to focus again on the posterior fossa to see how is the cerebellum and is there something that is draining the liquor and making it the bones like this. So I would like to see the posterior fossa in this case also.
So what do we expect to see in the posterior fossa, ma'am?
So I would expect to see that the cerebellum is pushed backwards and the cisterna magna has gone down, like it is also pushed, and that is a typical of the banana sign that appears along with that. And that's called the Charry-2 malformation, which I would be seeing in this, that the whole, because of the some leak that is coming from down the spine there, the liquor is drained and that pulls the cerebellum downwards. And that results in the typical banana sign formation that is there. Although lemon sign is not specific to Charry-2 only, so we can have lemon sign number of other condition also, like cystic hygroma and CDH. But if we are having the banana sign also, we are more suspicious of Charry-2 or the open neural tube defect. Like that is what we'll see though. So you'll be seeing the posterior fossa as well as evaluating the spine in detail to see where is the what is the point of leakage of the thing. Yeah, so here we see that we are having a spinal defect which is leading to the leakage of liquor, and that is pulling the cerebellum downwards and giving the picture that is there in the skull. That is a very typical sign of leakage. So this is these are the things that we look into.
Absolutely correct. This is the sagittal section of the spine, as ma'am has rightly brought about. We can see that the skin here is intact, but suddenly there is this defect in the skin with protrusion of this anechoic cystic lesion, which also has the spinal cord going into it. So this is definitely a case of open spina bifida and a myelomeningocele.
Yeah.
Correct, because it has both the neural elements as well as
the spinal.
That is correct, ma'am. So how would you counsel this patient, ma'am?
So whenever we get a case of Sherry 2, we know that we need to do a Sherry 2, open neural tube defect in that case, which you say. We need to do a detailed ultrasound to see if there are other anomalies which are there. We always tell the patients to get an amniocentesis for microarray if there are associated genetic components also, because that will help us counseling in the patients about, so for example, if they want to continue, then later on, if they want to have the surgery later on, postnatal or antenatal surgery is also there, plus fetoscopic surgery that is coming up. So depending upon the site of the lesion and as well as the amniotic microarray findings, we can counsel the patient, and then that is something that we can do.
Correct, that is correct. So if it is isolated, usually open spina bifida tends to be non-genetic, but if, as ma'am rightly said, it is associated with other abnormalities, or if it is a recurrent case of open spina bifida in spite of having taken periconceptional folic acid, then we need to start thinking of a genetic etiology and offer genetic testing. So that is correct.
Yeah.
And as ma'am has brought,
in India, I don't know how much of fetoscopic surgery is happening. And of course, a fetoscopic surgery offers more benefit than a postnatal surgery, because the meninges are not exposed to amniotic fluid initially, as all the elements inside the spinal cord are not exposed. And so less damage is there if the fetoscopic surgery is done as compared to the postnatal surgery. And that is one of the things. But I don't know how much, but in foreign countries, it is happening quite early. They are doing it. And there is a significant motor function, better motor function if it is done in the fetal life as compared to the postnatal life. So I don't know which centers are doing here in India. I don't know about that.
Yes, in India, we do not, as you rightly said, ma'am, in India, there's hardly anyone who is doing fetoscopic surgery for open spina bifida. But in countries, especially in South America, where termination is not an option, or where people are pro-life, even in the Middle East, there are centers which are doing surgery for open spina bifida in utero with, as you rightly brought about, improvement in the motor functions post-birth. So that is why the surgery. Yes.
Yeah,
Yes,
the third thing that is important.
Suppose genetic testing is not. Suppose this genetic testing comes normal, then how our counseling will go in this case?
Ma'am, genetic testing will only be offered if there is an abnormality. So, I mean, if there's an isolated spina bifida, we usually don't talk.
If it comes out normal, genetic testing is normal, then
then
open spina bifida.
Yeah, then we have to tell them about the postnatal surgery here in India, because the prognosis of postnatal surgery and the support after that, what they will receive, depending upon the segment which is affected in the case there. So if it is a higher on, then the prognosis is not good. But if it is lower down there, the prognosis can be better, and that is like a postnatal surgery. They can say 82% of the cases they can have a good outcome, but it requires a lot of support. So in India, when the patient themselves are affording all the expenses, we have to be very cautious about the counseling, because if the baby is with the lot of motor functions which are not good, the later on life will not be that good. Am I right?
That is correct, ma'am. That is correct. Not only motor functions, we are also concerned about the bladder and the bowel functions, because those are, in fact, they affect the quality of life even more.
Exactly.
And that is something which we also need to make the patient aware of. And as ma'am said, that if it doesn't have a genetic cause, then another thing that we can counsel them safely is that the chance of recurrence is low, because had it been associated with some syndrome, then based on the nature of that syndrome or mode of inheritance, we would give the recurrence risk. But if it's an isolated non-genetic reason, then the chance of recurrence is low, provided we offer periconceptional folic acid in the next pregnancy.
Yeah. And
now today, as Bela ma'am has eloquently brought out, diagnosis of open spina bifida is actually made at the time of NT scan. So Dr. Ruta would. Okay, ma'am. If you wish to continue, you can.
Yeah, I want to continue because I am very fond of doing first trimester scan.
I see. Perfect. Then you are the right person for this.
Because this is the scan that gives us a lot of opportunity to see the fetus in detail, and the posterior fossa is very well seen in this, especially in such cases like in almost all the fetuses. If we do a transabdominal as well as a transvaginal ultrasound, so transvaginally you can can see the posterior fossa very well. And if you're seeing that the peduncles are pushed backwards in this stage also, that's a typical of a crash sign or increased BS upon BS OB ratio, like brain stem upon the brain stem and
Now,
occipital
in these
bone
two
ratio.
images, can you tell me which one is open spina bifida? In which fetus would you suspect open spina bifida?
Just let me see, where is your picture? Your picture is coming just in the cis. So in the just 1 minute, just like minus.
Right.
Yeah. So the one on the right, it is, this one is not having the typical of the hyperechoic lines, and the intracranial translucency is lost here. Okay.
Yes, that
And
is
this
correct.
one has a better intracranial translucency, and the four are there. So there is a loss in my
Correct,
right
that
hand
is
side.
That is correct. So normally we see three black lines in the posterior fossa. Here we are seeing only 2. So there is loss of the intracranial translucency, and as ma'am rightly said, this is the fetus where we would be suspecting open spina bifida.
Also
And
a
this,
dried up sign. Yeah, it's a typical
so
dried
would
up
you like to
sign
comment
because
on this image, ma'am?
yes,
What image
again,
is this?
yeah, I'm not able to see a very nice cerebellar peduncles in this. They are actually going up to the back, if I am right on this comment. Yeah, they
Yes,
are
this is
pushed
the crash sign.
posteriorly. Yeah, they are pushed very much posteriorly there. Yeah, so there has to be a hypoechoic area in between the peduncles and the cranial bone, which is missing. That is got the initiation of the cisterna magna there. Yeah, they can see the small lesions. So very early signs can be picked up, and you can see if there is a dried up brain. You are like seeing only the most of the brain tissue there and less of the fluid around, then you should suspect and see the intracranial translucency, the lines that are there. You can measure the brain stem and the occipital brain bone ratio. That is one of the things that's there. So that one which
So here
you
is the spine.
Yeah.
Here is
you
the
can say,
spine,
yes,
which is
showing
showing us the defect.
Yeah.
So when we see a loss of intracranial translucency in the brain and this crash sign, then we look for the spine carefully. And if you can appreciate here a small lesion, open spina bifida in the spine. So I think now I would request Dr. Ruta to please take up the next case.
Okay. So this is the image of 19 weeks as it is seen. So in first image, we can see nicely 2 peduncles of cerebellum. And in second image, I cannot see the vermis. I think the second image shows lack of vermis. There is a splaying of the 2 cerebellar peduncle. And there is abnormal collection of fluid also in the posterior fossa. So I think, and it seems that there is a connection between fourth ventricle. So this goes for posterior fossa anomalies. We have to do differential diagnosis of all posterior fossa anomalies by taking neurosonogram, the next level.
Correct. That is absolutely correct. So when we see such an appearance on a screening axial plane, we will do neurosonography. And so Dr. Ruta did neurosonography, and this is what she saw.
Okay. So I think we should first of all calculate BP angle, brainstem vermis angle.
So what is the cutoff, ma'am, that you use for brainstem vermis?
Normally it is
differentiate between
what I do in my practice, that I take 19 as a normal, and more than 19, then I see that where it is going. If it is more than 45 or it is like going to 70, then I'm damn sure that almost it is Dandy-Walker malformation. But if BB angle is less than 45, it's around 26 to 30, then I go more for black pouch cyst. So 3 things: black pouch cyst, vermiagenesis, and Dandy-Walker malformation. All are complex, and we need to differentiate these 3.
Any role of Vermian biometry or Vermian morphology, the appearance of the vermis?
Vermian, definitely. There are Vermian nomograms are available. We have to calculate the Vermian size also. So by calculating the Vermian size, we can put it in the chart, whether it is coming less than 5th centile or not. We can see whether it is coming in the normal centile.
So this was a baby at 19 weeks. And if you did a good neurosonography, do you think you would need an MRI? Or do you think MRI gives you any advantage over a neurosonography at 19
Yes,
weeks?
I would definitely suggest MRI, but that is on the latest 24 or 26 weeks. MRI gives more sulci gyri information. So cortex information, if I want to take, that is the best done by MRI. Sonography has its own limitation, even if you do 3D.
So at 19 weeks, would you be offering MRI?
No, at 19 weeks, I will
This
not
is
offer.
correct. So at 19 weeks, since the ultrasound resolution is quite good and we don't expect much of cortical development, at 19 weeks, we would not be doing MR. But as Dr. Ruta has rightly said, in the later part of pregnancy, later half of pregnancy, when the cortex develops more and it's difficult to see on ultrasound, then MRI is a good option to look for cortical development. Excellent. So in this case, if brainstem vermin angle was 30-degree, ma'am, and the vermis was normal in size, so what would your diagnosis be?
I think it's black pouch cyst.
Yes. And how would you counsel a patient? So at 19 weeks, you are telling something is there in the brain. So how would you counsel this patient if it was an isolated finding?
I'll counsel in a positive way. I'll say that prognosis.
Would you
is good.
offer genetic testing?
Yes, I'll offer that is what I'm going to say. I'll definitely offer genetic testing. I'll offer microarray to see any chromosomal abnormality.
Okay. So what do you think Blake's pouch cyst has an association with chromosomal abnormalities? Isolated Blake
Very
pouch?
less, very less.
Very less. Okay. Okay. And what about follow-up? How would you like to follow up this patient?
Follow-up, I'll take after 6 to 8 weeks.
Right. And what would you look for in follow-up? What do you expect? What can happen?
In the follow-up, I'll see that whether the Burmian size I'll see. Then I'll see that any problem in the cortex, if any malformation I'm getting in the occipital cortex.
Do you expect the lesion to resolve? Can it resolve in utero?
Yes.
Yes. So yes. So Blake's pouch is actually a
regresses.
remnant. Yes, and normal embryonic remnant, and we do expect in majority of cases for it to resolve antenatally itself. Very seldom can it grow in size and require any kind of postnatal management. So that is correct. So now from the head, we move on to the fetal abdomen. So Dr. Rakhi, would you like to take up this case, ma'am?
There is an anechoic cystic area in the lower part of the abdomen. And as we can see the vessels around that part, most probably these are umbilical arteries. So this is bladder, urinary bladder, and it's around, the diameter is 12 mm. So it's megacystis. And because the diameter is usually less than 7 for a normal bladder, and it is more than 7, so it is megacystis.
Perfect. So this is a coronal image of the body. This is the stomach. And as ma'am has rightly said, this is indeed a persistently distended urinary bladder, which did not empty despite multiple examinations at 14 weeks. So what next, ma'am? How would you like to counsel a patient with isolated megacystis?
We would like to counsel that we have to do a detailed scan along if we see a megacystis, and if it's and we have to look serially about the size of the bladder, and we have to also look about the liquor around the fetus, and also we have to look about the kidneys, and if it increases like if it increases serially, if we see the size, and if it's increases more than 15 mm, then it's most probably lower urinary tract obstruction. And we have to also look for the genetic testing also, like invasive testing, amniocentesis.
Correct. So is there any particular size of the bladder which makes you think about a genetic abnormality? Like when do we suspect a chromosomal abnormality more?
If it's between 7 to
bladder
15 mm,
size?
then it's most probably chromosomal anomalies. And if it's more than 15, then we will go for, it will be more about lower urinary tract obstruction.
Correct. So more the distended, it is more likely that it's due to an obstructive cause. We must also not forget that sometimes megacystis is just transient. And so when we follow up these patients again, say after 3 to 4 weeks, it can resolve. So these cases usually tend to have a good outcome, the transient cases. And in fact, the case which I showed you, which was a transient case, so it resolved after when we followed her up after 3 weeks. and this patient did not opt for genetic testing and went on to have a normal baby. So we must always remember the physiological cause of megacystis as well. And as you rightly said, if we see any other associated abnormalities, we should think in terms of a genetic syndrome and offer invasive testing.
Yeah. So just one point, I was going through the whole thing, like reading about it. So even it was like, even if it is like 15 millimeters and you are suspecting a luto, you should actually always see that the chromosomal anomalies are not missed. So it is very probable that it can look like a luto, but it is having a chromosomal anomaly or a marker there, which you can see. So this
I
is
think
one
whenever
thing.
there's a structural anomaly in the fetus, we always offer genetic testing. So it's about how you, I mean, when you counsel, you will tell them that I'm offering you testing, but there is a chance that it might come out to be normal if the bladder is over distended. So I mean, even if before you ask, we offer a test, we always give them a pre-test probability. So the pre-test probability of having a genetic problem is low if it's a very big bladder and isolated, and of course it's high if it's not a very big bladder and it's associated with certain abnormalities. So that is correct. And now we come to the next case. Dr. Anita, would you like to take it up, please, ma'am? This is a case of a 26-year-old primary at 34 weeks.
34 weeks, and it is the transverse section of abdomen, axial section.
Yes.
Where, as you have labeled, we see the bladder, right side, and the stomach, and there is a sonolucent area with echogenic flakes inside. Is it double bubble sign? I don't know. 34 weeks. This is a cyst. Mesenteric cyst.
I will tell you, ma'am, this is a female fetus. So does that help in narrowing the differential? The most common cyst that we see in the third trimester?
Ovarian cyst.
Perfect. That is perfect. The most common cyst that we see in the third trimester usually, because the second trimester scan will be absolutely normal and you will see this large cyst suddenly popping up in the third trimester. And especially these flakes, ma'am, they are usually due to hemorrhage within the cyst, and these give a clue that it's a ovarian cyst, especially because it is close to the bladder. Since we don't see, I'm not showing any communication with the stomach, so that is why we rule out double bubble here. Otherwise, I would try to show you a communication with the stomach if this was the double bubble appearance. And I would suggest that there is polyhydramnios, because when there is double bubble or a duodenal obstruction, then there is a lot of polyhydramnios. So I would have given that clue. Also, I switched on color Doppler here just to show that this is an avascular lesion. So it's a cyst and not a vascular mass. So that is why I've given the images that I have. And ma'am, why do you think ovarian cysts typically appear in the third trimester?
These are the, I think, simple functional or hemorrhagic cysts.
But they are typically, the typical history is that they are always seen in the third trimester, ma'am. They never appear in the second trimester. So any particular reason that comes to your mind as to why they would be seen only in the third trimester?
No idea.
No, right. No worries, ma'am. Anybody else who would like to discuss? Ruta, probably. Would you like to?
Maternal hormones. No?
Exactly. So the level of maternal estrogens, as well as the development of the fetal hypothalamo-pituitary ovarian axis takes place after 29 weeks. So because of those hormones, typically these ovarian cyst is something that you see only in the third trimester and you seldom see. So if I see a cyst in the abdomen in the first or second, ovarian cyst is usually never a differential. And when we see it in the third trimester in the female fetus, it is always the first differential when we see a cyst in the lower abdomen. So how do we follow up these cysts? How would you follow up, say, if a patient came at 32 weeks? So how would you like to follow up the patient?
I think they resolve spontaneously, so watchful expectancy and serial sonography will help. And they don't have any genetic association also. So we must reassure, and our counseling should be like that only to the patient.
Yes, that is correct. Most of them are innocuous. They tend to resolve postnatally. Rarely some of these cysts can undergo torsion, which can happen both in utero and postnatally. And there are certain signs which make us think in terms of a torted ovarian cyst. So can anyone describe those signs? Any signs that you know of in literature?
Yes,
Whirlpool
whirlpool is the
causes
sign we typically see in the
torsion.
adult ovarian torsion, but in the fetus, it's very difficult to look at the at Nexa or the whirlpool. So, looking at the ovary, if the ovary is very thick-walled, normal ovarian cysts are usually very thin-walled, anechoic. But if you see a very thick-walled ovarian cyst and with a fluid debris level, typical fluid debris level, then we start thinking in terms of ovarian torsion. Also, if a cyst rapidly changes in size, if it rapidly increases in size on follow-up, then again we think in terms of torsion. So this is about ovarian cysts. As ma'am has rightly said, they are usually isolated and do not require genetic testing unless there is some other associated abnormality. This is just to differentiate simple from complex ovarian cysts. And then we move to the next case. Dr. Bhargav, are you still there with us? No.
TTV.
Anybody who would like to take this up?
Hello.
voluntarily?
Yes, madam.
Sir, would you like to take up this case of a
Yes,
24-year-old
sure,
primate?
ma'am.
Yes.
Yes, she is 24 years old and with 19 weeks primary gravida. We are typically seen actually bilateral club foot. So whenever we see this type of bilateral club foot, just we will go through detailed history whether she is diabetic or not, because with diabetes and detailed neurosonography with spine assessment. So it will give clues whether it is isolated finding or associated with any genetic syndrome. Yes, ma'am.
That is correct. Sir, any other point in history that you would like to ask besides diabetes? Any other point?
In history means in a family, anyone, because this is a single gene disorder, sometimes it runs through family. It is not like in first pedigree, maybe it is third pedigree also, means grandparents or grandparents also, some they have some this type of and through 2 to 3 generation it will be like silent, and again it will come in new couple.
That is correct. So, clubfoot or many limb abnormalities have a familial etiology as well. So, it's important always when you see limb abnormalities to take history in the family, because sometimes the patient might have been treated in childhood for the clubfoot and may be totally normal. So, the parent will not show any abnormality or deformity when they visit you in the clinic, but they might have had it when they were born. So, it's important to take a family history. Right,
Yes,
sir.
ma'am.
So if you have this case with bilateral clubfoot, what are the tests that you would offer her at 19 weeks, sir?
First of all, I will advise for amniocentesis, as whether it is isolated finding or isolated structural malformation or associated with any genetic syndrome. If it comes, if that testis comes normal, means there is no, and I will go for microarray with whole exome sequencing, because sometimes it will be a part of skeletal dysplasia also. So yes.
So, but skeletal dysplasias would usually be associated with short femur.
Short
So in
short
this,
femur, yes.
yes. So in this case, there was no short femur. Sir, besides direct testing, you said neurosonography, any other testing? Any other ultrasound? Detailed ultrasound?
Cardiac assessment.
Cardiac?
Yes, cardiac.
Correct. So fetal echocardiography is something
yes,
else that,
yes, ma'am.
yes, because limb abnormalities can be associated with abnormalities in the heart. So basically, to rule that out, we would also offer fetal echocardiography. And sir, if everything turns out to be normal, say after testing, should we see her again at 36 weeks only?
Yes, ma'am. Nothing to.
Or should we keep her on regular follow-up?
Any structural malformation at if we are finding an absolutely normal, for at least if 20 weeks first scan is normal, then I will call at least 28 week, not 32 week, ma'am.
Yes, so it's always a good idea, especially in clubfoot, to keep them on 4-weekly follow-up, because we don't really know, because as
and
you
some
said
developing
rightly,
abnormality also we can find out.
Precisely. So we cannot rule out evolving abnormalities. So it's always better to keep these people, these patients on follow-up
regular
4-weekly, so
follow-up.
that if something else, if something else pops up, so we can pick that up and, accordingly counsel the patient. So I think that brings us to the end of discussion on clubfoot, and then we move to the next case. Anybody would like to volunteer for this? This is a case of an abnormal face.
Yes, on the left side, it's the coronal section of the face. showing the nose and the nostrils, and the upper lip. We have a sonolucent defect in the upper lip, which is it is a case of cleft lip.
And what am I trying to
And
show on the image on the right, ma'am?
on the right side, it is the post-maxillary triangle.
Correct. So what about the base of the triangle, ma'am?
Yes, and the base of the triangle is broken. It is
So that
defective.
would
There is a defect.
Palate.
Cleft lip and cleft.
That's
So there is a
palate. Yes.
yes. So there is a unilateral because
Associated.
it's only on one side. So a unilateral cleft
Yes,
lip
yes.
and palate.
Palate.
Correct. Right. So how would you counsel this patient, ma'am, now at say 20 weeks?
Okay. We must do the detailed sonography.
Yes,
If
ma'am.
baby is having cleft lip, and then we have already asserted that it is a unilateral thing. It may be bilateral also in few fetuses. So we have, it is unilateral. So we have to do complete neurosonography, detailed ultrasound of the baby to see other defects, other associated things. Though, yes, it is associated with some genetic. In some cases, it has got genetic association also. So we must go for genetic testing also. And
Which would be in the
if
form
it
of
is
what, ma'am?
unilateral, amniocentesis.
Correct. Absolutely. No role of screening.
Yeah, no role of screening. And if it is unilateral, then the prognosis is good if genetic testing is normal.
Any specific ultrasound, ma'am, maybe that you would like to offer? Fetal echocardiography, perhaps?
Yes, yes, fetal echocardiography has to be.
Yes, again, because ma'am, facial abnormalities are associated with heart
With cardiac
abnormalities.
anomalies
So
also. Yes.
yes, so we would definitely offer fetal echocardiography in these cases. So there's a whole lot of syndromes which can be associated. The risk of chromosomal abnormality is higher if you see bilateral clefts, if there is involvement of cleft palate, and also if the cleft is median. So as you saw in cases of holoprosencephaly, there's a median cleft. So if we see a median cleft lip and palate, then we again start thinking in terms of chromosomal abnormalities. So as Bela ma'am had told us, we are again in the era of inversion of pyramid of prenatal care. So nowadays this diagnosis is actually made in the first trimester. So if Anita ma'am, if you don't mind, may I pass it on to ma'am, who is fond of first trimester screening? May I ask ma'am to?
Yes.
Yeah,
ma'am,
so
please,
yeah,
please.
you see a gap in the palate in the first image. In this, there's a as compared to this. So whenever you are doing an NT-NB scan and you're focusing on the nuchal translucency, at the same time you just have to focus on the palate also and see if there is any gap there. And if you find a gap, then you need to follow it and see that if it's actually increasing, and then you can actually diagnose that cleft palate at this stage only.
And looking at this image, we can actually say that this is a case of bilateral cleft lip and palate. And why do I say that?
There are two kinds of this thing.
But by looking at this image, yes. First is the gap, and
Gap
second,
is-
there is one more thing which is very
There's I don't find there is a protrusion of the
Protrusion.
proboscis.
Proboscis.
The hyperechoic shadows between, and I see that that has shifted the nasal bone also slightly. If it is there,
So,
that's there.
yes, this is known as premaxillary
Premaxillary
protrusion. So when there is a bilateral cleft lip and palate, the tissue protrudes out, this premaxillary tissue. And this is, if you see this with this defect, we know automatically that this is a bilateral cleft lip and palate, because this is the premaxillary protrusion. So as ma'am has rightly said, we always look for this intactness of the maxilla when we look at the NT image. So we look at the nasal bone, the NT, the maxilla, and we look at the intracranial translucency. And here the intracranial translucency is fine, but there is this big defect in the maxilla, which we also confirm. So what is the plane that we will use to confirm these findings? Another second plane?
You take it in the axial plane. Yes, now you can see.
This plane?
Post maxillary.
Yes. So Anita ma'am, would you like to again take this?
Yeah, this is
max.
post-maxillary triangle, which we have focused. On the right side, it's a normal post-maxillary triangle. The tip of the apex of the triangle is formed by nasal bones, and the sides by the ethmoid process of the maxilla, and the base is formed by maxilla, alveolar process and maxilla. And on the left side, there are two sonolucent defects in the base of the triangle. It is broken, and apex also, the nasal bones, they are widened. There is a gap between the both nasal bones.
By looking at this image, we see not only bilateral cleft lip and palate, but we can also
see the proboscis, the coming out of
unossified nasal bone. So since the apex is absent, so this baby also has an unossified nasal bone. And what are these two dots, ma'am? These two dots?
The mandible.
Correct. So this is known as the mandibular gap. So normally we should not see any gap in maxilla, but we should see a gap in the
mandibles.
Correct. If we don't see the mandibular gap, what do we suspect?
It's micrognathia.
Correct. Micrognathia. So yes, if we don't see the absence of mandibular gap in PMT, that is premaxillary triangle view, makes us suspect micrognathia. Absolutely. Now, this is the last case that we have for today. And Dr. Bhargav, would you like to take this up?
Yes, ma'am. This is the second gravida with 26 week pregnancy, and we can see with fine anterior transverse view of both kidney, and one is sagittal view. In one kidney, right side of kidney, it looks like echogenic but not enlarged, and one cortical side, one cyst, we are saying it is clear. We can, and with normal amniotic fluid. Okay. So
correct.
maybe
So are these cysts as well? What are these black things that you see?
No, it's a pyramid side.
Correct. So one must differentiate the normal medullary pyramids from this cyst. Yes. So cyst is black. Medullary pyramids are a little gray. If you notice, they are not that black.
And there is good CMD. Corticomedullary differentiation is also good. So
good.
Okay.
So what is this in the middle? This thing?
Renal pelvis.
Correct. That is the renal. So it's just to make us familiar with the normal renal anatomy. And I've already said the amniotic fluid was normal. So if you see a renal cyst with normal amniotic fluid, nothing else in the baby, sir, what is the next thing that you might think of doing?
Just cortical cyst, I will give just positive counseling regarding just postnatal abdomen KUB. USG KUB and just follow up after delivery. But we'll monitor for
anything that you would like to do to kind of see.
Yes, in maternal I will see. In maternal kidney also, in any type of kidney abnormality, I will check maternal kidney also, because sometimes it will give clues to whether it is inherited or not.
Perfect. So that is the correct thing. So when we see something in the kidney, especially just an isolated cyst, it is usually a part of fetal autosomal dominant polycystic kidney disease, and we want to rule out whether it has something which is inherited from the parents or whether it is something sporadic. So we usually do scan the kidneys of both the parents, so both the mother and the father. In this case, the mother also showed presence of a renal cyst. So this was actually a case of ADPKD in the fetus, and the mother also having the same, though she was totally unaware about it. So this is just to show you again the importance of checking the parents when there is something in the fetal kidneys.
Yes.
So as you have rightly said, sir, the ADPKD has a very favorable outcome, and most patients usually remain asymptomatic for a major part of their life. If there is ADPKD and one of the parents, so what would be the recurrence risk in this patient, sir, in this lady? What would be the chance of recurrence in her next pregnancy?
Autosomal dominant, 50%.
50%. Since it's an autosomal dominant, so there's a 50% chance that she can again have a baby with ADPKD in her next pregnancy. And finally, this is another type of...
Dr. Divya, how our counseling will go? Number one. Number two, why it is not multicystic kidney? How will it look like? How to differentiate between that?
I was just going to show you another case of polycystic kidney disease. So, ma'am, counseling, as I said, ADPKD is usually a disease which it manifests usually in adult life, and the typical manifestation varies. Some people can present at 20 to 30 years, some can present as late as 50 to 60 years. So this is something that parents have to know, and especially when one of the parents has it, then it's more easy for them to understand and appreciate that if they are not symptomatic or they do not have a lot of issues, then they are more accepting of the diagnosis. But what is typically done, we do have genetic testing even antenatally for ADPKD. So if parents want, that can be done to confirm the diagnosis, or nothing needs to be done if the baby and the amniotic fluid remains normal. And as sir said, postnatally, we can do a KUB and routine urine examination. And then usually these patients are followed up in the care of a pediatric nephrologist who just usually does nothing except an yearly assessment of the kidneys by ultrasound and urine examination. So they're just kept on follow-up and told to take good care of their kidneys in terms of having lots of fluids, not taking excessive salt diet, and basically what all of us need to do. That is what they need to do, because nothing else needs to be
extra care.
Yes. And there are, as you said, you were asking about multicystic dysplastic kidney. So multicystic dysplastic kidney, in that the whole kidney is a little big. There is no corticomedullary. That is why I stressed on this corticomedullary differentiation. Usually, multicystic do not have this nice corticomedullary differentiation, and there are multiple, as the name suggests, multiple cysts of varying sizes.
Non-communicating.
Yes, so cysts are non-communicating. So you'll have multiple varying sizes. So they'll not be of the same size. Some will be very small, some very large. So very haphazard kind of cysts. No normal corticomedullary differentiation, and the kidneys are usually enlarged as well.
Enlarged.
So those definitely have a poor outcome because there is no normal renal parenchyma in those kidneys, and those are totally non-functioning kidneys. So if there is unilateral, then a person is born typically with a single kidney because there's only one kidney which is functional. And if it's bilateral, then it is non-compatible with life, multicystic dysplastic. But there is one more type of polycystic kidney which I was wanting to show, and this is the last slide of this discussion. So Dr. Ruta, would you like to see this? I'm showing you two kidneys here.
Both are enlarged kidneys with showing loss of corticomedullary differentiation.
Correct.
And I think this, I would label it as a ARPKD.
Yes, you can see tiny cysts, very small cysts.
Very tiny cysts.
Yes, very tiny cysts within both the kidneys. So this is what autosomal recessive polycystic kidney disease looks like. Big kidneys, no corticomedullary differentiation, and very, very tiny cysts throughout. And these typically, again, have a 25% risk of recurrence and a poor outcome. So even though this baby has a normal amniotic fluid now,
later on, oligohydramnios.
Yes, over a period of time, say even in pregnancy or postnatally, the renal function deteriorates much more fast in these. And these patients are also predisposed to something else. Some other organ is also affected in postnatal life, which is that, if you recollect, ARPKD. They can have congenital hepatic fibrosis, so they can have liver disease as well in later life. So by later I mean in the first decade of life. So even if it is compatible initially with life, they can later have liver problems as well. So this is just to show you the spectrum of renal cystic disease, ADPKD, ARPKD, and we discussed multicystic dysplastic kidney. So that brings me to the end of this panel discussion. And I would like to thank all the esteemed panelists for their active participation, which made this panel meaningful and enlightening and totally worth it for all of us. So thank you so much for taking the time out of your busy schedules. It was a pleasure to host
you.
Thank you very much.
Pleasure. It was a very nice panel. Thank you.
Excellent panel, brilliant interaction. All the panelists has taken the discussion as a fetal medicine expert, and it was very excellent interaction. Thank you all the panelists and wonderful moderation, Divya ma'am.
And thank you, Dr. Sarfaraz. Thank you so much.
Thank you so much.
Thank you, sir, for having us.
For taking
Deepika,
such
final words.
Yeah, so thank you so much, Dr. Divya, and thank you all our esteemed panelists. I think everyone answered just like fetal medicine experts and expert radiologists. Even
Yes.
though I think some of them might have been core obs and gynae specialists, but सब लोगों ने बहुत अच्छे से answer किया. So it was wonderful discussion, and your cases were just excellent, Dr. Divya.
Yes.
Your videos and cases, and we
Yeah.
all
Yeah,
came
great selection
away
of the cases, and to
understanding
the
so many
point,
things.
discussion has been taken
Yes.
out with all the panelists, and everything was going very smoothly,
One word I
seamlessly.
would say, Dr. Sarfraz,
Yeah.
one sentence only.
Yes, Dr. Ruta.
The selection
Yes.
of moderator you have done, she was my senior
Oh,
in
Gampatar.
medicine, and I was her junior.
Okay.
At
Okay.
that time also, she was the
Right.
best student, best academic student in the entire lot of medicine. She is still there, and she has not left that no high level of academician. Kudos to her. If possible, in every moderation, you please take her.
That is very kind of you, Dr. Ruta, but it's very.
She was at that time also, she was a master of all moderation. She is still.
Yeah.
So
We
thank
fully
you.
agree with you. Thank
Very
you.
kind and gentle. Thank you so much.
Thank you
Thank
so
you. It
much.
was a
Thank
pleasure
you.
to host all of you.
Yeah.
Thank you.
Thank you so
Thank
It was
you,
much.
Divya ma'am.
wonderful.
Thank
We
you.
would like
Thank
to
you.
thank
Thank you.
our chief guest, our guest of honor, our
And
special guest, our two wonderful speakers, Dr. Sarfaraz, Dr. Bela Bhatt ma'am, and of course our excellent moderator for this session, Dr. Divya Singh ma'am, our chairpersons, and our very knowledgeable panelists for joining in, and for such a wonderful academic feast that has come across our way, that we have learned so much. And we would like to wish Dr. Sarfaraz Qazi the best of luck. Sir, देखिए अभी fast अपना break कर रहे हैं. It is his, he's having roza, so just see, it is his time. He's been involved with the academics as well as so as they say, science and science and religion, everything should go together, sir. And so we hope and pray that you for your elections, and
thank you, thank you.
best wishes, sir. And we look forward to the next edition of Well Women.
And thank you very much for the Corona team for providing us this platform.
Yes, and we,
Thank you.
the seamless platform that the Corona team has given, and they were excellent. They helped me to make the flyer and so many changes and updates of the CVs. So they were excellent. Behind
Thank you,
the
ma'am.
scenes. So thank you so much, Karuna, and thank you to all our esteemed faculty. And we hope to see you again in the next edition of
See you again. See
Well
you soon.
Women Masterclass.
Best
Sure,
wishes to Sarfaraz sir.
Thank you so much.
Thank you.
Best wishes.
Thank
You
you.
rock, sir.
Thank you.
Thank you.
Thank you, everyone. Thank you. And special thanks to Corona team. We will look forward to work with you. And heartfelt thanks for all the panelists, all the speaker, and our chief guest of honor. Thanks a lot for giving me the opportunity to put everyone on this platform on the name of Well Webinar Series, Well One Webinar Series. And hope we are going to continue this in coming future with all your blessings and help and support. Thank you, and thank you very much, Deepika. It is only because of your hard work since last 15 days you are calling everyone on behalf of me. You are doing everything. You are in connection with the Corona people to managing the sequence. You are talking with everyone. You are getting CVs and photos of everyone for the flyers. And बहुत shukriya आपका. It would never be possible without you. This webinar is from me, dedicated to you only.
Thank you so much. Thank you so much, sir, for the opportunity. And we hope to again have the next edition as whenever. I think probably it's on 25th of 25th of March.
So I invite you all to join that webinar also. That will be on another topic.
Yes, definitely. And thank you so much, sir. And
thank you, Aman Bhatt sir, for being here for all the webinar.
And
the Bela Bhatt ma'am is here. Thank you very much for your excellent talk. Thank you, everyone. Thank you, Corona. Thank you, Deepika. Everyone, thank you. Okay, bye-bye.
Okay, bye,
Have
sir.
a nice evening.
Bye, Dr. Ruta. Thank you.
Bye.
Thank you for being there. Thank you.
Thank you, Ruta.
Thank you.